We welcome you for our national quiz on bone and soft tissue tumor. So this is a prequel for our fourth Onco Orthocon, which will be held in Gujarat Cancer Research Institute, Ahmedabad on 24th and 25th June in Ahmedabad. So we will be eagerly waiting to welcome you for this event. So for today's quiz, I am here, Dr. Abhijit Salunke. With me is Dr. Nandlal, Dr. Hello. Yeah, so we welcome you for this quiz. And to give overview and understanding of this quiz, we will be having 25 questions which will be there, and you have to answer these questions in 15 minutes time. So all contestant needs to answer these questions in this 15 minutes time. There is a pop-up screen to start the quiz. You can join in that part, and this is through a Google form. So out of all the contestants, we will be selecting top 6 candidates according to the time which you give the answers. So try to submit all your answers as fast as possible so that you can go for the next round. Next round, there will be a second round, third round, and fourth round. So we'll tell all the rules accordingly when you get selected. So we wish you all the best so that you come in top 6 candidates list. So there will be a timer which will be shown on your screen. So you need to answer these questions very fast and correctly. So first round is the qualifier round. There will be a screening test of 25 questions. These needs to be answered as fast as possible. There will be 15 minutes time. And after this, answering your questions, we'll have 2 talks. One is by Dr. Naveen Thakkar, sir. He is Honorable Secretary of Indian Orthopedic Association, and you know all him very well. Sir is an eminent speaker and a senior orthopedic surgeon. So there will be 2 talks after this qualifier round. And after this 2 talks, this will give some time for assessment of all your answers so that we can choose the top 6 contestants who will go for the next round, and we'll inform the top 6 contestants who will go for the next round, and we'll invite them according to our platform method, and then we'll start the next round. Yeah, so we can start the time. So just wish you all the best and answer the question as fast as possible, and best of luck. Yeah. Good evening, friends. Thanks for your excellent participation. And we have a very good number of attendees for this quiz. And meanwhile, we are calculating all your scores. It will take around 25 to 30 minutes for a big team. So we have around 10 people working with us. Tirji is there, Jagdishji is there, Manmit madam is there. Multiple people are working. So we are calculating all your answers, and our big team is there working hard to calculate all your responses. So meanwhile, it will take 20 to 25 minutes, and in that timing, we will have two lectures. One will be by Dr. Naveen Thakkar sir. So sir needs no introduction from because he's a eminent orthopedic surgeon and he's secretary of Indian Orthopedic Association. Sir is working in Ahmedabad. So sir will be talking about what are bone tumors and how we approach them. Second talk will be by me in recent advances. So we will have first talk by Dr. Naveen Thakkar sir, and so please kindly hear him patiently, and it will be very good learning opportunity for everyone that how to read a X-ray and how to approach for bone tumors. So we'll have talk by Naveen Thakkar sir. So we welcome Dr. Naveen Thakkar sir for his talk.
Welcome to you all here at Quiz, Onco Ortho Quiz. I welcome you on behalf of Indian Orthopedic Association and the Gujarat Cancer Research Institute and Gujarat Orthopedic Association, and from the team who is working for this of Dr. Abhijit Salunke. He has worked very hard for this work. And you are also invited for the next conference here. So let us start. I have been given one duty to start the back to basics and orientations about the onco-orthology, right? So I'm starting here. You know that this program is for all the PG students, for the basics of the onco-ortho. So we'll be touching some basics of the onco-ortho. Small part, very small part, just to ignite the things or thought process in the minds. This is the case, 40 years male, pain and swelling over the left wrist since 4 months. Physical examination is must, and it is done, and the surgeon has said that it's a tenderness, swelling, wrist movements are painful. What could be the diagnosis? That is the first thought process after seeing this X-ray. So you must know how to read the X-ray and what could be the possibility of it. The main thing we have to decide is whether it is a benign condition or it's a malignant condition. Have you gone through this problem? This is one example, typical example of bone tumor in the pediatric. It was thought of ABC or simple bone cyst, benign tumor. Anders nailing was done. And what happened? You can see that it became the rhodate sarcoma. It was a sarcoma. Biopsy was showing the Ewing sarcoma. So without any tissue diagnosis, you should not go for any surgery. And this has happened like this. And you can see here, this was the incision, and that was taken care into the whole surgery, and the total femur excision was required because it is spread to all. This is the post-operative radiograph. This has been given by Dr. Abhijit for his surgery he has done. So why this is happening? Why this is happening? What are the issues? What are the problems? How to plan whenever you see any case of the tumor or onco-ortho surgery? What are the pitfalls? What are the problems? And what are the possible solutions that we have to think for first for the diagnosis? Once your diagnosis is there, tissue diagnosis is there, you can make a definitive procedure. Then and then you can do it. So we'll be learning together. Back to basics. फिर से school चलें. That is the A, B, C, D, E, F and the Z of the tumor. This is devised by Abhijit Salunke, and he has written the paper also, and it is published. So what is the A to Z radiology of the bone tumor. A is the age, whether it is a skeletally mature or immature. B is for the bone, which bone is inward. Mark that. Again, the bone is which part of the bone? That is the epiphysis, metaphysis, or the diaphysis. C is for the characteristics, whether it is a lytic lesion, sclerotic lesion, or a mixed lesion. And what is the content in that tumor? What is the matrix? Is it osteoblastic? Is it chondroblastic, ground glass, or it is something else? D is the distinctness, how distinct it is. It is well-defined or ill-defined. If it is well-defined, it is going towards the benign. If it is ill-defined, it is going towards the malignancy. What is the exterior of the bone? That is a periosteal reaction. You know the Codman's triangle. Soft tissue mass. Is there a soft tissue mass there? And F is for the fracture, pathological fracture. And that will depend, that finding will make your management clear. And the last is the Z is the zone of transition, the narrow zone of transition or a wide zone of the transition. We'll see one by one. Once you have this type of the tumor patient, then you have to go by this chart, A to F and Z. Suppose this is the picture which we had seen previously. Age is skeletally immature patient or a mature. Sex is male or female. Number of lesion is the single lesion. Location is the epiphysis, metaphysis, and it is centric. Morphology is borders, is well-defined borders with narrow zone of transition, bone restriction, osteolytic matrix is the ground glass, periosteal reaction is no, soft tissue mass is present, and the pathological fracture is no, but it is impending. The lesion looks to be a benign bone tumor, most probably giant cell tumor of the distal radius. But histodiagnosis, the tissue diagnosis is must for this. Again, the second case, which we had shown in the example, age is skeletally immature, bone is proximal, bone metaphysis and diaphysis, characteristic osteolytic. The content and the distribution is ill-defined with wide zone of the transition. Exterior of bone, periosteal reaction, soft tissue swelling is there. Fracture, yes, pathological fracture, it is not there. Lesion looks to be a malignant bone tumor. So you have to take care at that place. Now let us see the third example. Here it is a distal femur and the look is little bit different. You can see, anybody can guess it. What is that from A, B, C, D, E, F and Z? Again, we do same exercise. Age is skeletally immature, open growth plate. You can see here. Bone is femur, metaphysis and the diaphysis. Characteristics is osteosclerotic, white triangle is there. Content is osteoid matrix, white triangle is, you can see the cortical destruction is absent. Distribution is ill-defined. Exterior of bone, you can see the sunburst, typical pattern of the periosteal reaction with the Codman's triangle. So that clears your picture. Fracture, pathological fracture is visible. If you zoom the picture, you can come to know that there's a thin line of the fracture and there is a wide zone of transition. So it is suggestive of malignant bone tumor. So radiograph of skeletally immature individuals showing the lesion in metaphysis and diaphysis of distal femur with indistinct borders and the wide zone of transition, which is sclerotic osteoblastic lesion with interrupted type of periosteal reaction of sunburst pattern and Codman triangle with soft tissue mass and a pathological fracture. Lesion looks to be malignant bone tumor and most likely osteosarcoma of the distal femur. So borders and zone of transition has to be checked. And there you require more investigation like CT scan and MRI other than the X-ray. But from the X-ray even you can come to know about the differential diagnosis of 1, 2, 3. Which is the most common and what could be the second possibility and what could be the third possibility. So zone of transition is very much important, that is whether it is a well-defined or it's ill-defined in the wide zone of transmission. Let us see here, example, you can see here, the narrow zone of transition, slow growing, sharply outlined, sclerotic bone. because there is a chance of healing slow growing. So this looks like benign tumor. Wide zone of the transition, fast growing, poorly defined border, because it is a fast growing and it is aggressive, most likely to get fracture. So it is a malignant tumor. What about the content? Tumor matrix, osteoblastic matrix. You can see like this, quote and fluffy. And the chondroblastic matrix, just like a popcorn, punctate annular comma-shaped calcifications, typical of chondroblastic. Triangular area of subosteal bone that is created when the lesion raises the periosteum away from the bone. How the Codman triangle happens, you know exactly what is the theory behind this, and who name coined it. It's a Codman. Elevated periosteum is forming an angle with the cortex. It was first described by the Ribert in 1914. It is named for the Ernest Henry Codman, who described it in the setting of the Ewing sarcoma. Right? Advancing aggressive tumor destroys periosteal newborn formation, it ossifies. The periosteum does not have time to ossify with cells of the newborn, and so only the age of the raised periosteum will ossify. Whole periosteum will not ossify. So that becomes a pseudo triangle. So that is Codman's triangle. Here you can see in this picture, this is the Codman's triangle. So beware of all these pitfalls in diagnosis of the tumors, particularly. Go back to the basics. This is the paper which I was referring to, which is published by Dr. Salunke. And there is also one more paper, proposed radiological evaluation score of the bone tumors, REST. Here they have tried to devise a scoring system. The scoring system, it is less than 3, suggestive of benign tumors. And the score is more than 3, it suggests the malignant tumor. Right? So you must see, this will help you in the management, scoring system. So what is expected from you? To learn the basics, and do not take the biopsy without thinking the plan of the surgery, because the surgery, this biopsy scar should also come in that area of marking and in the planned surgery. So always when you feel that you need a second opinion, take a second opinion of onco surgeon. Take a help, get a reference. And the tissue diagnosis is the only final diagnosis to define the treatment methodology. You will learn more and more details. Welcome to Ahmedabad for 4th Ortho OncoCon at Ahmedabad at 23rd, 4th and 25th June 2023 at GCRI. And you will learn each and everything from basics to advanced, more and more advanced. 3D technology, virtual reality, different methods of treatment, recent advances, everything will be available here. So please do not forget to attend this meeting. This is a very important meeting. And again, I invite you on behalf of Indian Orthopedic Association. Again, this year's CME is done by Gujarat Orthopedic Association, and the theme is innovation technique paper which change my practice may change your practice. So submit your innovation, your idea, or your specific case which change your practice and may help our colleague to change their practice. So welcome to IOCON 2023 at Lucknow. And now the final appeal is, as a PG student, you can become the associate member of IOA. And once you clear, you get converted into life member. And you will have an advantage of getting the young mentorship. We have for young fellows, there is a mentorship program of 100 mentorships. We have earmarked 50 to 60 lakh rupees for young orthopedic surgeons. You can choose your specialty. You can choose your mentor, and you can have a one-to-one conversation with the mentor and learn the things which you want to learn. So please become the associate member here and here only. It is online. Just click join IOA on the IOA website and you will get all the details. So please join IOA. It is advantageous. Later on, you can go for the foreign fellowship. This year we had 134 applications of foreign fellowship, which is a benchmark in the IOA. There is a better communication between the IOA office and the members. So there are more and more applications, and it has become now transparent. All the markings are put on the IO website so that you can come to know how to improvise for get the desired position next time. And you can know how to improvise yourself. And for members, those who are already life members, GBM has passed already. So please update your data, update your Aadhaar to prevent future litigations in IOA and fund getting used in the legal expenses, which we can use for academic purposes. Thank you very much for your kind attention. Thank you very much. And I wish a great success to this program of PG Quiz and the complete conference on 24th and 25th June at Ahmedabad at JCRI. Thank you very much to you. Thank you.
Welcome to the session on advances in orthopedic oncology. The work in this presentation has been performed at the Gujarat Cancer Research Institute, Ahmedabad. What was the treatment for bone tumors in the past? It was amputation, followed by the era of limb salvage surgery, and currently we are in the era of 3D printing, augmented reality, and virtual reality. What can be the future? It can be that we can print bone, muscles, nerve, and everything. So this was the past, present, and future. So currently we are printing bone models. That is a pelvis case where the tumor is colored into red. A case of tumor involving the femur where a customized plate of titanium was prepared. And we can see the examples of 3D printed scapula and 3D printed talus according to the patient's need and size. So these are patient specific implants. What is 3D printing? So this is a simple video showing what is 3D printing, meaning metal, powder or polymer is placed into a machine which prints the object. Here the insect is preparing a cocoon around it himself. We can see here a 3D printer where plastic models of various sizes and shapes are prepared. We will see few examples in this presentation. So this was a case of malunited neck of femur in a patient who was previously operated with dynamic hip screw fixation. We had prepared virtual model for this patient. So this is a video showing virtual model of this case. The case was planned very properly and we intended to take 3 cuts, one near the greater trochanter, second cut just below it, and third cut at the level of the neck of the femur. So intraoperatively, we need to use multiple times image intensifier TV. So we prepared a special jig or a cutting device which will aid us in cutting the bone precisely and perfectly. This is the jig which was prepared, which will help to cut it intraoperatively at 3 levels. So upper cut, middle cut and lower cut were taken. Osteotomy was done. Dynamic hip screw was placed for the patient. This is how the dynamic hip screw was placed. So with the help of this technique, we reduce the number of intraoperatively shoots and radiation to the patient and the doctor. Going to next case, a case of tumor involving the femur where we intended to cut the bone at a level which is just above the knee joint. We may require few special techniques to cut the bone at exactly at the level where we intended. So we prepared a jig, means a cutting device. A bone model was prepared according to size of the patient where the tumor was, and a special jig was prepared. So we can show all the steps to the patient's relatives, explain them all the steps very properly before surgery, what are the advantages and disadvantages of this procedure. So this cutting guide or cutting device will be placed on the bone of the patient. There are few holes which are made in the area which is just above and below the tumor with safe margins. We cut the tumor bone into above and lower part. So two osteotomies are taken. So the jig is placed over the patient's bone, and we are taken a proximal cut and the distal cut. Distal osteotomy was taken. The tumor bone was removed. On another trolley, all the soft tissue was removed. So we can assess how this was removed very properly and what was intended. And we can cross-check with the help of the model what was planned and what was performed. So remove all the soft tissue, place this bone into liquid nitrogen. So this is a container of liquid nitrogen, minus 180 degrees. Treat it for 20 minutes in liquid nitrogen, then bring it at normal temperature with gradual thawing. So this is a cryotherapy treated bone which will be placed back at its original site. So it's a cryotherapy treated autograft bone fixed with help of plates and screws. And here we can see the knee joint of the patient and the hip joint of the patient was saved. This is how screws are placed. Next case is use of 3D printed model and 3D printed plate. So here a customized plate was prepared. This is how the plate planning is done. So all virtual planning is done first on computer. Get a CT scan done, convert it to DICOM. From DICOM, you convert the design into STL file and print the model and the plate. Here it's a titanium plate. So simulate all the steps which will be performed intraoperatively beforehand, anticipates all the complications and the events which we can face intraoperatively. Here we can appreciate the plate is specially prepared with few parts of the plate which are solid. So this decreases the risk of the plate breakage. And we don't require any contouring of the plate intraoperatively. So this bone again was treated with pedicle liquid nitrogen. Slide the plate directly and it will sit perfectly at the location where you intended to fix it. Next, we will see example of 3D printed bone, that is 3D printed talus. Here it was again printed with titanium material. This is the bone model. In the blue is the talus bone and in the red is the calcaneum bone. We can see here the tumor was involving talus bone. The tumor was removed. The artificially printed talus was placed where we intended to place. We can appreciate here the ankle movement, and this was 1 year plus follow-up of the patient with good ankle movement and back on his legs. Next, we will see example of 3D printed scapula, the shoulder blade bone. So this was a case of Ewing sarcoma involving the scapula bone. Patient was treated with neoadjuvant chemotherapy followed by a MRI, and metastatic workup was performed with PET CT scan. In this case, we had prepared 3D printed scapula bone model and 3D printed titanium implant. So this is how the virtual planning is done before the surgery. What will be the dimensions of the implant that are planned very properly. So this planning takes at least 2 weeks from planning to getting the implant in our hand for surgical exercise. This is how the patient is placed on operation theater. Proper painting and dripping is done. Remove the tumor with the biopsy scar. This is how the 3D printed model looks. We can appreciate here size of the 3D printed model is around 30% smaller as compared to what was resected, because finally we need to do good closure as minimal soft tissue is available. This is the resected specimen. This is the 3D printed implant which will be placed. We need to fix this implant with the shoulder bone, that is humerus bone, and in this case we had used Prolene mesh. Next was attachments between the clavicle and the acromion, which was done with the help of fiber wires and fiber tapes. After this, the remaining muscles were used for closure. This is how the acromioclavicular joint is stabilized. Fix the implant with the chest wall with the help of fiber wires and fiber tape. Next, we will see example of recent advances, that is expandable or growing joint, which is used in pediatric patients. So this case is of a proximal tibia growing joint. This is an indigenously prepared implant with titanium material, and this works on warm gear mechanism, means you have to turn few threads and the limb will grow of the patient. So coming to this case, it's a Ewing sarcoma of tibia treated with neoadjuvant chemotherapy, and the patient's implant was prepared. Skin incision was given, the tumor was resected with good margins. This is how you do the intraoperative assembly. This is how the growing mechanism works. So maximum expansion can be achieved is 5 to 6 centimeters based on your resection. So every time you need to give small incision, take the patient in operation theater and expand the limb. So this is very useful procedure for pediatric patients. Next, we will see few examples where limb salvage surgery is not possible. So we have alternative procedure that is called rotation plasty, means you are converting a hip disarticulation or a high above knee amputation into a below knee amputation. So you are converting high above knee amputation into a below knee amputation, means the ankle joint works as a new knee joint. So remove the tumor, save the neurovascular bundle, turn the limb by 180 degrees, and your ankle joint works as new knee joint for this patient. We can see an intraoperative video here where the neurovascular bundle is saved, the artery and veins are saved, and all other parts are cut. The tumor and remaining muscles are removed. Turn the limb by 180 degrees so that your ankle joint works as a new knee joint for this patient. These patients require a special prosthesis which needs to be attached. Cosmetically, it's not that great procedure, but functionally, it's very excellent procedure for the patient. We will see small animation video how this is performed. Remove the tumor, save the artery, vein, and nerve, rotate the limb by 180 degrees. So this is life with or without legs. The child is back to his school and all his activities of daily living. He is using this special prosthesis and is walking very well after using this prosthesis. So functionally, it's very excellent procedure for the patient, and you are converting a knee amputation, above knee amputation, into a below knee amputation. So he is able to climb stairs, doing all his activities, donning and doffing the prosthesis alone, and back to all functions. Next, we'll see example of never giving up, life with or without hands. A patient with tumor involving the distal end radius, which was treated with below elbow amputation. A special type of joint is prepared, an artificial prosthesis, which is prepared, again an indigenous joint. It's a special electrical joint, and patient is able to do all his activities of daily living. He is himself an engineer and driving his car back. So what is the future? Virtual reality, 3D printing, and augmented reality. To know more about all these modern techniques, please register for our conference, that is 4th OncoOrthoCon. Visit our website oncoorthocon.com. This conference will be in Gujarat Cancer Research Institute, Ahmedabad on 25th and 25th June. So this is how virtual reality surgery can be performed by the attending doctors. So we are having few sets of these special type of gadgets, that is Oculus. So what can be the future? It's really amazing. We are trying to prepare artificial intelligence radiograph reading method. So we are preparing for last 2 to 3 years this method. For any queries, just email us and please join us to know about all these recent advances in Ahmedabad on 24th and 25th June. And please register for our conference, that is 4th Onco Orthocon, and visit our website www.oncoorthocon.com. Thank you very much. Yeah, good evening, friends. Hello. So can you hear me? Yeah, so we have got all the answers from all the contestants and the top 6 I have been selected. So we'll introduce everyone who are the 6 contestants with us. So first is Dr. Tabish Tahir Kirmani. So
Yes, sir.
hello, Dr. Tabish. So just you can introduce yourself, where you are working and what you are doing.
Yes, sir. Yes, sir. Good evening, sir.
Yeah, good evening.
I'm Sir Dr. Tabish. I am presently doing Sir FNB, Fellowship in National Board in Joint Replacement Surgery from Apollo Hospitals, Delhi. And
Great.
currently, I am mainly engaged in these joint replacements: knee, hip, shoulder, elbow, and ankle.
Nice. So we welcome you for this program. Secondly, we have Dr. Somak Banerjee. So Dr. Somak, where are you working? In Bengal?
No, sir, I am in AIMS Raipur, third year orthopedic junior residency.
Yeah. So third contestant with us is Dr. Kshitij Mehta. So Dr.
Hello,
Kshitij,
good evening.
welcome you.
Yeah. Good evening, sir. Sir, I am a third year resident at Government Medical College, Patiala from Punjab.
So welcome you. Next contestant is Dr. Ravi Ranjan. So good evening, Dr. Ravi.
Yes, sir. Good evening. Yes, sir. I'm sir, third year resident.
Ravi, your internet is bit weak. Okay. Next we have Dr. Aditya Patni. Hello, Dr. Aditya.
Am I audible, sir?
Yeah, you are audible.
Sir, I'm audible now, sir?
Yeah, you are audible. You can speak.
I'm from Armel Hospital, New Delhi. Third year PG resident.
Okay, great. And last contestant with us is Dr. Abhishek Jain.
Good evening, sir. I am myself Abhishek Jain, and I am doing a secondary DNB program from Civil Hospital, Lucknow.
Yeah, great. So we are contestants from all over the India, and it is really great to have you all. And we will encourage you all for just registering for our conference also. So it will be a good event, and you can tell all your colleagues that we have program from basics of orthopedic oncology to high-end things. So we have got this Oculus, and we have prepared few softwares. So that will be the high-end thing, and we can start from basics also, that how to read a X-ray, how to send a specimen, use of mega prosthesis, and all important things will be there. So for today's quiz, we will see that what are the next rounds. So we have next round, that is second round. So we have 30 questions total, 5 questions per contestant. So we will start from A, B, C, D, E, F. So A, B, C, D, E, F, total 30 questions, 5 questions per contestant. So every contestant will get 5 questions. Correct answer will give you 10 marks. So plus 10 for correct answer. There is negative marking system, so it's minus 5 marks for every wrong answer. The questions will move from first, second, third, fourth, fifth contestant. So for first contestant, we will have 5 questions. When he finishes, then we will go to second contestant. So from Dr. Tabish, we'll go to Somak, then Kshitij, then Ravi, Aditya, and Abhishek. So that is the sequence for this round. So first, Dr. Tabish will get 5 questions. He need to answer them. If he gives correct answer for every answer, he'll get 50 marks. If he gives any wrong answer, it will decrease 5 marks for each wrong answer. And passing is not allowed for the questions. So there will be a round where passing will be allowed, but in this round, there is no passing allowed. So this is second round. So we'll give all the instruction as per the rounds. If you have any query, just ask me. You're free to ask any question. So again, I'll clarify it. It's 30 questions, 5 questions for each contestant. If he gives correct answer, it's 10 marks plus. If he gives incorrect answer, it's 5 marks minus. There is no passing of the questions. Each one has to give his 5 answers, 5 questions, and then we'll go to the second contestant. And we'll start from Dr. Tabish, means from A, B, C, D, E, and F. So after this round, we'll calculate the answer, total marks, and it is live. Just everyone can see the number of marks what everyone is getting. So if any query, just ask me now before starting this round. And for response, you need to type in your box. That box is there. So you
Where is the box?
Yeah.
Where is the box, sir?
There is a response box here.
Q&A box is there.
Chat box you have to need. Chat box you can see. Everyone can see the chat box.
Yes, sir. Chat box is here.
So, सबको दिख रहा है chat box? Yeah. Just you can say hi, hello, anything. That Zoom chat.
But how will we okay, sir.
Yes, बोलिए. Yeah.
Is it,
This
sir?
is not a buzzer round, so we'll
This
have
is
that
not a
round
buzzer
also.
round.
Now this is that you need to just write your answer. So there are questions. So or you can speak verbally also, not a problem. Not a problem. So anything you will do for this round.
Okay, this is not a time bound.
No, this is not time bound. You have 5 questions. You read the question, you analyze it, and just tell the answer to us. So correct answer 10 plus, and incorrect answer minus 5. And if you pass, then it's 0 marks for that.
Okay, sir.
Yeah. So Kirji, are we ready? So we can start with Dr. Tabish. So best of luck. And it will be really good. But this is also our first time. So mine is the first time. I'm a quiz master. So if anything happens wrongly, just tell me that because it's totally new format for us also. Yeah.
Yes, sir.
Dr. Tabish, there are 5 questions and you can answer that in proper sequence. So this is your first question. Which is the following genetic abnormalities may occur in a patient with osteosarcoma? So these are the genetic abnormalities. These are some chromosomal translocations, mutations, and multiple types of genetic abnormalities may happen. So you need to answer what is the correct answer. So if you know the answer, you can say which is the answer. If you want to pass it, you can pass it also because there are negative markings. So take your time and you can answer.
I have typed the answers.
Yeah. You type the answer. Okay.
Yes,
Yeah. So we can go to the next question. So which of the following tumors has worse prognosis?
sir, you told that
You
typing.
can say that. You can say it. No problem. So you can say it.
Okay, sir. The first for first my answer is E. Choice E.
Answer is B.
No, E, sir. E for England.
For elephant. Yeah. So your answer is correct. It's correct answer.
Okay.
So it's second question. Which of the following tumors has worse prognosis? So few tumors are having good prognosis, few are having bit poor prognosis. So your options are: first is paraosteal osteosarcoma, second is periosteal, third is adamantinoma, fourth is chondrosarcoma occurring in a patient with multiple exostosis, and lastly is conventional osteosarcoma. So here it's not written conventional, but it's osteosarcoma means conventional osteosarcoma. So these are the answers, and you can say your answer, which is your of choice. Yeah.
Sir, I need some time, please.
Yeah, you can take your time, no issues. You can think and take your time, no problem. Dr. Nandlal has helped and he has taken great effort for preparing this. So Dr. Nandlal is fellow with us for bone tumors. He will be here with us for 2 years. So post MS is a fellow in orthopedic oncology with us, and he was the phys master for the patients. Yeah, Dr. Tabish, you can tell your answer.
Yes, sir.
If
Can we
you're
pass?
not,
Can
if
we
you're not
pass
sure,
on?
you can pass the because it's negative marks.
Okay, no, sir.
Next question will go.
No, sir. Please let me.
Yeah, no problem. You take your time.
Just half a minute more.
Yeah, no problem. Take your time. No problem.
I have this difference between type D and type E.
No, you can take your time. Just tell us.
Only yes, it is one among the D and E. But
Yes,
I'm
yes.
confused.
Because all answers are very near. C, D, and E are very close. So it's a hint for you.
C is excluded. I know C is
Yeah.
not.
So just
It is
take
between
a
D
choice
and
between D
E.
and E. It's like कौन बनेगा करोड़पति? हम भी help कर सकते थोड़ी बहुत.
I will go with E, sir.
What is your answer? D for Delhi.
E, sir.
E for elephant. Yeah. So your answer is correct. It's osteosarcoma.
Yes, sir.
Conventional osteosarcoma is more poor as compared to all other types. Adamantioma is a malignant tumor. Chondrosarcoma is again a malignant tumor. Parosteal and periosteal are a bit better. So
Yes.
conventional
Parosteal has the good prognosis, and periosteal is in between the parosteal and the conventional.
You're correct. Very much correct. So it's plus 10 marks for you. So we'll go for next question, third question. So which of the following is the primary cellular abnormality in Paget's disease? So Paget's disease of the bone. So its options are, which is the primary cellular abnormality? So all cells types are there. So osteoblast, osteocytes, osteoclast, and plasma cells. So this is a bit a difficult question for me also. So I need to take help of Nandlal. That what is the answer of this? So it's a bit tough for me also. So A and B looks nearly similar. So C, D, and E. These can be a bit helpful. So B, C, D, E.
C and E are excluded. It's between B and D.
Yeah. So you need to tell which is the correct one.
Yes, sir. Kindly give half a minute.
Yeah, Dr. Tabish.
Osteoclast D.
D is your answer. D for Delhi.
Yes, sir.
Yeah. So it is what others think. It's correct or incorrect?
Correct.
Correct. So it's correct. So
Thanks.
audience poll will take its correct answer. So it's very nice. Great. You answer all the 3 questions correctly. It's really great. So we'll go for 4th question now.
Okay, sir.
So this is a bit easy now. So a radiograph, if you have seen the lecture before by Dr. Naveen sir, so a lesion in distal radius, skeletally mature individual, which is light take, and what is the differential diagnosis here?
But
So,
we need to go as spot diagnosis, sir.
so you can tell what is your diagnosis. It's A, B, C, D, E, none of the above, fibrous dysplasia, giant cell tumor, osteosarcoma, or ABC.
It is between.
This is a bit easy answer.
It is an easy, but it can be difficult also between GCT and ABC.
So you need to differentiate radiologically. So there are always differential diagnosis in bone tumors.
Yes, sir.
So which is the nearest possible what you think? It's age is skeletally mature and the lesion is involving distal radius, expansile, well defined,
The
narrow.
patient is skeletally mature.
So it's skeletally mature. ICC.
Then it is, yes. Then I will go with GCT.
So your answer is C. Yeah, that is correct answer.
Okay, sir. Thank you.
Great. So your answer is correct. So you have 40 marks now. So we'll go to next question, 5th question. So a patient with a radiograph showing a lesion in the soft tissue in the knee area, and these are the possible differential diagnosis based on the imaging. So it's an MRI and it is showing some lesion in the patellar area. So the differentials can be here: Hoffa's fat pad, chondroma knee, osteochondroma.
Is it, sir?
2 lesions also together, or none of the above. So one
So
X-ray
this-
we have seen. This is now an MRI for you.
Okay, sir. This is chondroma knee.
So you want to
No, I don't. I'm not going with chondroma knee. I'm saying that I have not heard of an entity chondroma knee.
So all these are some entities we think so for tumors.
I will go with Hoffa's fat pad.
So you want to go with Hoffa's
Because
fat pad.
chondroma knee is I have not heard of an entity of chondroma knee.
So
Osteochondroma is
what is
not.
our audience poll? What are other friends? Yeah, Dr. Somak, Kshitij, Ravi, what do you think? He is correct or wrong? He was
Hyper,
having
it's a
100%
hyper,
strike rate previously. So what do you think? He is
Hyperintensity
again correct or wrong?
so it's a
Yeah.
hyperintense Hopper's fat pad. So
Yeah. So what do you think
could
it is?
it couldn't be osteochondroma.
Yeah.
And so might be means chondroma is a new term for me also, might be chondroma.
Okay. So Kshitij, what do you think?
Sir, I think the Hoffa's fat pad because it is hyperintense.
Fat pad. Then next is Ravi.
Yes, sir. I think Hoffa's fat
So Hoffa's pad again. Aditya.
For me, it will be chondroma knee.
So Aditya is going for
I don't
chondroma. And
think it
lastly, Abhishek.
So it is T1 weighted or T2 weighted?
This is a T2. This is
I think
T2
it's
film.
T2.
T2.
I think it's T2.
So I think that it may be a synovitis type of thing also.
But there is an option of E also. So for E, you want to go?
Okay, there's an option
Yes,
of E also.
Yes,
E
sir.
also none of the above. So the answer is B. It's a chondroma knee. So Aditya was correct. So still, it's great answers by Tabish, and he has scored 40 marks out of 50. So one wrong answer. So 5 minus. So still, it's very good score. That 35. It's really great. So we'll go next to Somak.
Yes.
Yeah, Somak, you are ready?
Yes, sir.
Yeah. So Somak, we'll start your questions. Yeah, Tirji, we can start for Somak. So now for Somak, the question first is, which of the following factors portends the worst prognosis? So this is important, worst prognosis. There are some good prognostic markers and there are bad prognostic markers. So which is the worst prognosis in a patient with osteosarcoma of distal femur? So one, age means young patient is having better or poor, or old patient is having better or poor. Next is location in proximal femur. Next is grade. D is discontinuous tumor, means there is some tumor in any other part of the body or other bone, or the size of the tumor. So 3 centimeter, 4 centimeter, 10 centimeter. So which is the worst? So all may be bad prognostic markers. So young patient bit better, old patient bit worse. So that is also a bad prognostic marker. Grade, high grade and low grade, that is again a bad prognostic marker. And size, so small size we think that it may be bit better, and bigger size may be bit bad. So out of all these worst markers, which is the more bad marker? So you need to answer that.
So D, discontinuous tumor.
So you think it's a D, discontinuous tumor. So Abhishek, what do you think? It is correct or wrong? Yeah, Abhishek?
So I think it's C, grade.
Great. So, but all are bad. So, Somak is correct. It's correct. D answer is correct. So, discontinuous tumor is bad prognostic marker in all of these. So, we go for next question. So, Somak has got 10 marks. So, again, next, which of the following tumors has most favorable prognosis? So, most favorable. One is osteosarcoma. Again, osteosarcoma means conventional type. Second is Ewing sarcoma. Third is dedifferentiated, means chondrosarcoma are having different types. So dedifferentiated type. Next is parosteal osteosarcoma, and lastly sarcoma in Paget's disease. So which is having better prognosis?
D, parosteal osteosarcoma.
Do you think it's D, parosteal osteosarcoma? So Aditya, what do you think? Is correct or wrong?
Yes, he is correct.
Yes, correct. So parosteal is correct answer. So it's nice that you are given two quick answers. So 20 marks are there. So we go to third question. And the third question is, which of the following genetic abnormalities, again something related to genetics, occurs in patient with synovial sarcoma?
So the options haven't changed.
So the options are not
So Kirji, the options are not changed. The question is changed, but the options are not changed. So can we check this? Can we open the question? Just give 1 minute time. So we'll just check this, what we had written. No, we'll just check it. Something we need to find it. Just give me 1 minute time. So I'll just tell the answers. Which of the following genetic abnormalities occur in patients with synovial sarcoma? So your options are: one is activating mutation of FGFR3, activating mutation of FGFR3. This is first option. Second is missense mutation. Missense mutation in EXP1. Missense mutation in EXP1. Third is balanced chromosomal translocation. Balanced chromosomal translocation in T1122. Fourth is balanced chromosomal translocation TX18.
So TX18.
Just I will tell all the options and then you can answer. Fifth is missense mutation in retinoblastoma tumor suppressor gene. So I'll repeat the answer again. Activating mutation FGFR3, missense mutation in EXT1, balanced chromosomal translocation T1122, and fourth is balanced chromosomal translocation X18 and missense mutation in retinoblastoma suppressor gene.
So X18.
So you think the answer is D, X18?
Yes,
Tabish, what is this?
He's right.
He is right. So great. So all know the answers very well. Huh? You have studied very well. It's really great. This was tough question for me also. So nice. It's correct answer. We go for first question. So sorry for the technical glitch. Something happened from our side. So this is the spot diagnosis. There is some lesion in a patient who is young. MRI was done, and this was his MRI, showing the differential diagnosis here. Option A is synovial sarcoma of the knee. With the third question, similar question. So synovial sarcoma is a misnomer, and the newer name is not still available. It's still synovial sarcoma. Next is mycetoma of the knee. Third option is synovitis, and fourth is none of the above. So what do you think, Suma?
So I think it's A, synovial sarcoma knee.
So you want to lock the answer or you want to think again? Because it's a negative thing. So just think for half a minute. Take your time because we want you to be sure that what you want to say. Take your time, just read the imaging. It's a tumor session, but it can be a non-tumor case also because non-tumors are also mimickers. So one is tuberculosis, second is infection, third can be non-specific synovitis. Some arthritis also can mimic the tumors. So it's not that this is a tumor session that we'll have all the questions on tumor. So it can be something else also if you want to go for that answers. So it can be none of the above also. Just think, take your time and convey your answer. Take your time, read the imaging. It's some lesion anteriorly near the patella.
So I'm not sure, sir. So
So we want to pass this because you don't want to go for negative marking.
yes,
Yeah.
sir.
So
Yes.
this question is passed. So what are other friends think? This is the answer here. So Ravi, what do you think?
I think it's a synovial sarcoma, sir.
So you also think synovial sarcoma. Any other opinion from other colleagues? So Tabish, what do you think?
Mycetoma knee.
So mycetoma knee, yes. So some infection can be there. So this looks like a mycetoma of knee. You always need a biopsy diagnosis, but if you read the
There
imaging,
is a mass.
yeah, so there is a mass, then there is some dot-like things, circles are there, so more suggestive of a mycetoma knee. So it was good choice that you skipped this. It saved your 5 marks. So we go for fifth question, Dirjit.
Sir, is it sir mycetoma?
Yeah, it was mycetoma.
Okay, sir.
Yeah, so it was mycetoma. So this is a bit easy. A radiograph, skeletally mature individual showing a lesion in femur, which looks bit well defined, narrow zone of transition, no periosteal reaction, no significant soft tissue mass, some pain around knee, and he consulted a doctor and he did a radiograph for him.
So sessile osteochondroma.
So you think it's a sessile osteochondroma?
Yes, sir.
So any other opinion from our other friends?
No, it is simple.
So everyone is confident it's sessile osteochondroma?
Yes.
So it's a correct answer. So this brings Somak to 40 marks then. So it's a correct answer. So nice, Somak. Great. So we go next to Kshitij.
Yes, sir.
Yeah. Kshitij is our third contestant. So A, B, and C. So after Kshitij, we'll go to Ravi. After Ravi, we go to Aditya, and then we go to Abhishek. That is the sequence. So Kshitij, are you ready?
Yes, sir.
Yeah. So Tirjil, our question for Kshitij. So this is the first question for Kshitij. 55 years gentleman with soft tissue mass of around 10 centimeters. Biopsy reveals him high-grade malignant fibrous histiocytoma, MFH. And so patient with some tumor, which is of soft tissue. Final pathology was MFH. And which are the common locations where it can spread or metastasize? So can it go to bone? Can it go to lymph node? liver, lung, and kidney. So, which is the most common site where these tumors metastasize? Few tumors go to lymph node, few tumors go to lungs, few go to bone, few go to liver, and some may go to kidney. So, which you think which is the most common location where it can spread?
Sir, I'll go with A, bone.
So you think the tumor goes to bone. So what is the opinion of our house where it goes commonly?
D. Lungs.
Lungs. So
Most common is lungs, and
lungs.
for and the most
Which
common
tumor goes to lymph node? What do you think? Most the tumor which goes to lymph nodes.
Yes, sir. They
Which
go
are the
to
tumors?
synovial sarcoma.
Synovial
epithelioid-
sarcoma, clear. There is a simple mnemonic.
Cares. CARES. Yes,
Yeah.
sir.
So that goes to lymph node. So this was MFH. So these tumor go commonly to lung. So it is a bit hard luck. So your first answer was wrong. So it's -5. Just take your time, read the question properly. We need that all participants should do very well in a quiz. So we go to next question. So next question is, which of the following soft tissue sarcomas? Again, a soft tissue sarcoma is most likely to have mineral deposit within the tumor. So it's a tumor in soft tissue, and if you do a radiograph or imaging, you see some mineral deposit in that tumor. So options are fibrosarcoma, malignant fibrous histiocytoma, liposarcoma, synovial sarcoma, and epithelioid sarcoma. So just we saw something related to lymph node. So these are the tumors where you see something goes into the tumor and it is having mineral deposit in it. These are the options. So read the options properly and tell your answer.
Sir, I'd like to pass this. I don't know it.
So you don't know the answer, no problem. So Abhishek, what do you think? What may be the answer? So we had given some hint to him also. That just something we saw in previous imaging also.
Synovial sarcoma.
So you think which answer? Synovial sarcoma.
D.
Yes, sir.
Yes.
Synovial sarcoma. Any other opinion?
Yes, sir. It is D. Synovial sarcoma has
Synovial
mineral
sarcoma.
deposit.
So if you get a radiograph done, then synovial sarcoma may show some mineral deposit. Any benign tumor you know where there is some calcification mineral deposit? Benign tumor.
Enchondromas.
enchondromas.
Soft tissue tumor. We are saying soft tissue tumor. Hemangioma, you know.
Yes, sir.
Yes.
Hemangioma may have
Yes,
some calcification. Benign. If here it was a benign and options were hemangioma, then it would have been a tie. But here the option answer is synovial sarcoma. So you're passed. So you have saved your 5 marks. We go to next question. So next is a question. A patient with multiple hereditary exostosis and develops a grade 1 chondrosarcoma. So patient is having multiple exostosis and a specific part of the bone, means exostosis in scapula, turns out to be chondrosarcoma. So we have seen some 3D printed case here. At what are the treatment options available in our previous lectures? So what are the correct treatment options? So the options ranges from 1, it's preoperative chemotherapy and wide resection, preoperative external beam radiation, radiotherapy, and wide resection. Third option is only wide resection. Fourth option is chemotherapy and bisphosphonates like zoledronic acid or denosumab. And fourth option is radiotherapy and bisphosphonates. So these are all 5 options. So Kshitij, you can read all the options. It's a chondrosarcoma arising from a exostosis, and what are your treatment options? So read your options and just tell what you think that as a surgeon, what you will do. So you have done the biopsy, you have done the metastatic workup, and patient has come to you for the further treatment. So he's asking you what is your best treatment option in the case of chondrosarcoma.
So preoperative chemotherapy with wide margin of surgical resection. A.
So you want to go with
Sir, option A. Yeah.
option, which option you want to go?
A, sir, A.
A. So preoperative chemotherapy and wide resection. So what is the opinion of our house? Aditya,
Correct,
what do you think? Correct or incorrect?
C.
C.
You want to go to with wide resection. So chondrosarcoma requires only surgery.
Yes, sir.
Only a specific type of chondrosarcoma requires chemotherapy. So what that can be?
Dedifferentiated.
Dedifferentiated and mesenchymal. So mesenchymal may require and dedifferentiated may require. So just take your time,
Okay, sir.
relax, after this have a cup of tea or something. So you need to score good marks. So this is not good. So we need tough competition. So it's 35-40. You need to be near 30 something. So give all the next answers correct. So we go for fourth one. This is a bit easy. So you should be correct here. So it's a radiograph of a patient showing a lesion in humerus. Which part of the humerus involved here? It's metaphysis, partly majority of diaphysis, which is well defined, expansile, some pathological fracture, I think so there is there, and no periosteal reaction, no soft tissue mass. So the differential diagnosis can be giant cell tumor, fibrous dysplasia, simple bone cyst, aneurysmal bone cyst, or none of the above. So take your time and tell what's our best possible differential here. Yes, it is. You think it's benign? You think it's malignant?
Sir, it looks to be benign tumor only.
Yeah, so one is it's benign. So he is not
Right.
answer. Then you need to go with A, B, C, D. So which is the closest possible? Naveen sir described the Excel very nicely. So which are the tumors common in which part of the bone? So few tumors common in epiphysis, few in metaphysis, few in diaphysis, skeletally mature, immature. So this is very well defined. So it's benign. But according to the location of the tumor, you can say which is the closest differential here.
It could be a simple bone cyst.
So it can be a simple bone cyst, it can be an aneurysmal bone cyst, it can be a fibrous dysplasia, it can be giant cell tumor. You need to lock your answer.
Simple bone cyst, sir. C.
So you want to go with simple bone cyst. So yes, Tabish, is correct or incorrect?
So, if I have to go, I will also go with simple because
You think it's simple bone cyst? Yeah, Somak?
yes, sir. I would also have gone for simple bone cyst.
Simple bone cyst. Ravi?
Yes, sir. Same. Simple bone
Same.
cyst.
Aditya?
Sir, I would have gone for none. E.
None. So what is your differential? None then. What
I
is
don't know, sir. Maybe eosinophilic granuloma, but it is not that malignant.
Okay, so
but
you
it is
want
not
to
the
go
site
to
for
your
simple bone
eosinophilic
cyst.
granuloma. Yeah, Abhishek?
So
Last.
pathological fracture is present, so I will not go with simple bone cyst. I will go with fibrous dysplasia.
So something clinching here at the matrix of the tumor. So matrix means the content of the tumor. So osteolytic content and something you heard, ground glass appearance. So this can be bit zoom for you, but it was here. So it can be zoomed bit more. So it's a ground glass matrix. So meaning of ground glass is you just ground the glass and it's that type of matrix. So very classical of fibrous dysplasia. Fibrous dysplasia. Simple bones is the differential. Why we will not go more? Because it's expansile. Fibrous dysplasia can be expansile. Simple bones is less likely to be expansile. So that goes against simple bones. So the correct answer was fibrous dysplasia. So we need to cut 5 marks more. So last, Chitish, come on. You the correct answer. This should be more easy now. So radiograph of skeletally mature, male or female. It's a female, a lady with a lesion in the hip region. Something is there in the hip on the right side. So differentials can be osteochondroma, synovial chondromatosis, tuberculosis, avascular necrosis of hip with arthritis, and none of the above. So what do you think here? What is the closest answer you think on radiograph? She is a skeletally mature lady.
Yes, sir.
Lesion involving the hip region. And this is the radiograph. Take your time. Take 30
Sir,
seconds. Read the X-ray very properly. We want your plus marks from you.
Sir, I will go for synovial chondromatosis.
So you think it's synovial chondromatosis. So what is our opinion of our house? Everyone agrees with him? Yeah, so everyone agrees. So nice. So this was the correct answer. It's really good. So it's -5. Nice, nice. So next round you need to catch with the other people. So
Right.
next we go with Ravi.
Yes, sir.
So we welcome Ravi. And which of the following statements about unicameral or simple bone cyst is correct? So which is correct statement here? So these are the options. It is more common in males in 20 to 30 age group, more common in distal humerus. Close treatment should not be implemented in pathological fracture. Intracystic steroid is contraindicated. And lastly, intracystic bone marrow injection is an accepted treatment option. So Ravi, you can tell what you think. Correct option for simple bone cyst. Age, location, fracture, and 2 treatment options. So these are all 5 options available for you. So you think, take your time and give your answer. And what do you think it is?
I think it's E, sir.
E. So you think that
Yes.
intracystic bone marrow injection is an accepted treatment option. So E is your answer. So Yatapish, what do you think about
Yes, sir, it is correct answer.
D option?
Yes, sir, correct answer.
You think it's correct?
Sir, I
your
will go with
opinion?
C. Sir, C
Correct.
option. Close treatment should not be implemented in pathology.
So yes, so E is the correct option. So it's nice that Ravi had given first answer very correctly. So we go to the second question. So in which of the following conditions does secondary fibrosarcoma does not arise? It doesn't arise. A sarcoma doesn't arise from this type of tumor. So first option is Paget's, second is osteomyelitis, third is fibrous dysplasia, osteoid-osteoma, or a radiation-treated tumor. So secondary tumor arising from something prequel. It can be infection, it can be some tumor, benign tumor, which leads to some type of sarcoma, secondary fibrosarcoma.
I think it's D, sir. D.
I think it's D. D for Delhi?
Yes, sir. Yes,
so,
sir.
Osteoma, you don't think it can get converted to? So your answer is correct. So osteoid-osteoma doesn't get converted into these type of tumors. So your answer is correct. So we go to next question. So which of the following statements about osteoid-osteoma is not true? We read the question again. It's not true. So spinal osteoid-osteoma may induce painful scoliosis. It is characteristically associated with significant systemic symptoms. Occasional spontaneous regression has been reported. Radiograph shows typical nidus, which is of a small size, which is surrounded by zone of sclerosis. And lastly, osteoid-osteoma produces high level of prostaglandin E2, which is not true. So some options may be correct and one of them is not correct. So you need to find which is not correct for you, patient. In a osteoid-osteoma is a very common tumor, what we see in our OPDs. And
yes,
we
sir. I think it's B, sir. B.
RFA, radio frequency ablation. That is the latest treatment option, radio frequency ablation. We don't do surgeries for them. We treat, put an nidus, burn it at high temperatures. That is a treatment option. So what do you think?
It's B, sir, I think.
D for Delhi?
No, sir. B for ball.
B for Bombay. You want to go?
Yes, sir.
So
Yes.
osteoma is characteristically associated with significant systemic symptoms. So what is the opinion of our house? That is correct or incorrect?
Correct.
Correct. So he is correct. So nice, Ravi. You are giving good answers. So Kshitij, just you need to catch with Ravi now.
Right, sir.
So fourth question we go. So radiographs of a patient who is skeletally mature, showing a lesion in distal femur. If we go to the location, it is posterior aspect of the knee area, which looks to be involving the femur bone in metaphysis and diaphysis. So what is the best and common location of specific tumor here? So differential here is osteosarcoma, means conventional type, telangiectatic osteosarcoma, parosteal osteosarcoma, chondroblastic, or none of the above. Yeah, Ravi, take your time, read the X-ray very properly, think the differentials. Every tumor, most of the tumors are more common in specific locations. So distal and radial, distal and femur, proximal tibia, these are the common locations where tumors are there. And this tumor characteristically occurs in this part of the bone, distal femur and posterior aspect. So very
I
classic.
think it's C, sir. It's C.
C, you think it's a parosteal osteosarcoma? Yeah, Abhishek, is Ravi correct or is incorrect now?
I think
Very
it's
classical location. Yeah.
It's chondroblastic.
So you think it's a chondroblastic? Any other opinion?
Parosteal osteosarcoma. B. C.
Parosteal. So majority wants to go with parosteal. So its most common location, distal femur, posteriorly, very slow growing tumor. It takes at least 2 to 3 years for these tumors to grow. So the correct answer is parosteal osteosarcoma. So nice, Ravi. You given all 4 answers correct. So really great. So your answer is correct. It's parosteal osteosarcoma. We go for the 5th question now. So okay, easy X-ray. Some tumor involving the distal tibia in a skeletally immature individual. We can appreciate here the physis is open. So that is one good clue, that is the physis is open. Tumors common in pediatric age group. Common location, distal tibia, proximal tibia, then humerus, distal femur. These are common locations of these tumors. And the options are sessile exostosis, pedunculated exostosis, and chondroma. Both A and B, and none of the above. So Ravi, read the X-ray properly, skeletally mature, well-defined, narrow zone of transition, some bony growth, what it can be.
It's A, sir. I think it's A.
What do you think, A or B?
A, sir.
A. So, yeah, Kshitij, what do you think? Is
A,
it
sir.
wrong? Yeah?
A, sessile exostosis.
You also think it's sessile? Yeah, so what is the opinion of others? Is he correct?
Yes.
Yes.
Yeah, so he's having 100% strike rate then. Yeah, so it's a correct answer. So it's 50 marks. Great. Ravi, you have done very nicely. So congratulations. And other needs to catch him now. So Aditya, we welcome Aditya now. So Aditya is second last contestant of first round. So the question first for Aditya is, which of the following statements about Ewing sarcoma is true? Read the question. It's true. more common in African and American. More common in elderly patients, means above 50 years. Most common location is tibia. It is having equal incidence in both males and females, and it originates from cell of neural crest. So about incidence, about location, about gender distribution and its origin. So all 5 options are available. You need to read the options very properly and take your time and tell what is your answer. Yeah, Aditya, what you are thinking? So more in Africans and Americans, more common in elderlies, most common location, gender distribution equal in both groups, and the cell of origin. So which is
Sir, I
correct?
will go with D. Equal incidence in men and women.
So you think it's more equal in both. So what is the opinion of all other our friends? So what do you think? Yeah, Tabish,
Sir, E.
you think what? B.
E, sir. E. Neural
E
crest.
for, E for Delhi.
E, sir. E
Neural.
for elephant. E for elephant.
E for elephant, you think. So you think the origin is neural crest. Yeah, Somek?
Sir, I'm confused between A and D.
E and D. Okay, then Shitish?
Sir, I'll go for E, neural crest.
E. Then Ravi, what do you think?
So I think it's A or E, sir. I'm confused. So
E.
I
And
will go for
Abhishek,
A.
yeah? Yeah, Abhishek, what do you think? There is no negative marks here. You can tell your answer.
The cells from neural crest.
Neural crest. So Aditya, you what do you think? You are correct or wrong?
I don't know.
You don't know. So the answer is E. So first answer is wrong. So no problem. So you can take your time to read the answer properly. There is some hint everywhere that Ewing sarcoma is more common in pediatric age group. That is one thing. Equal, there is no equal incidence. Then which are the common locations? So femur is more common location, or we see commonly in pelvis or scapula. That can be the common locations. Young age group. So we go to second question. So which of the following variants of osteosarcoma is most commonly associated with pathological fracture? So what we see osteosarcomas, we have around 20 to 30% incidence of pathological fracture. So we have published few of our papers also that osteosarcoma with pathological fracture is having bad prognostic marker. So in 2014, we published one in JBJ's British that osteosarcoma pathological fracture is having bad prognostic marker, and the incidence is around 20 to 30%. So bit bad. And these patients fetch very badly because high chances of metastasis is there. So which variant is having more incidence of pathological fracture? So option A is osteoblastic, telangiectatic type, multifocal type, parosteal and periosteal. So more risk of pathological fracture.
Sir, option B, telangiectatic.
So you think option B, telangiectatic type, is more fracture risk. So any other opinion? Yeah, Ravi?
I think it's
Correct.
B, sir. Yes.
So
He's
everyone
correct.
agrees that it is B or C.
He's right, sir.
He is
Still
right.
injected.
So these tumors very commonly mimic with aneurysmal
Giant
processes.
cell tumor.
So they have a classical radiological feature, that is fluid level. So classical fluid level is seen in both these tumors, and in our radiograph paper, what we published it, in that tumor we were unable to differentiate it's benign or malignant based on our criteria. So it's a case where it's very tough that it's benign or malignant based on radiograph. Both will have fluid levels. So what is meaning of this fluid level? If anyone can explain, Tabish, what is meaning of this fluid level?
There are fluid
There is a
there's a
breed.
fluid with different density within the.
So the fluid density is different. So hemoglobin gets settled, and you have areas of two different
Yes, sir.
intensities on MRI. So more commonly seen in telangiectatic type, aneurysmal bone cyst, and in aneurysmal bone cyst type of giant cell tumor. So your answer is very much correct. It's telangiectatic type, and 10 marks for you. So we go to next question. So your marks become now 5. So third question we go. So this is a bit long question. 15 years boy with pain, swelling in the thigh with no trauma, some fever, blood test shows anemia, ESR raised. Radiograph shows a lesion in the bone with, this is important hint, lamellated periosteal reaction. Cytogenetics shows some translocation, which is very common for this tumor, and these are the options. So, what do you think?
सर ऑप्शंस शायद चेंज नहीं हुए सर.
ऑप्शन चेंज किए हुए ऐसा लग रहा है आपको भी, मुझे भी लग रहा है ऑप्शन चेंज हुए. So options change हुए हैं, so we'll give the correct options. So you
सर मैं
correctly that
Even's answer.
yes. So your answer is without
Ewing
giving any
sarcoma.
option, you can give your answer.
So Ewing sarcoma.
Ewing sarcoma. So you are correct. So the options here were written: osteosarcoma, Ewing sarcoma, chondrosarcoma, and none of the above. So your answer is correct. It's Ewing sarcoma. So we apologize here the typing mistake here. So your answer is correct. It's 15 marks for you. We go for fourth question. So a radiograph of a lesion showing some tumor in humerus, skeletally mature or immature, it's difficult to appreciate here. It's ill-defined with periosteal reaction, with ossification, and wide zone of transition. So your differentials here can be these options: osteosarcoma, chondrosarcoma, Ewing sarcoma, or none of the above. So what do you think?
I will go with option B, chondrosarcoma.
So you want to go with option B. So yeah, Ravi, what do you think? It's
Yes, it's correct. It's B, sir, I think.
You think it's correct? Then Tabish, what do you want to say?
Yes, sir, he's correct. It's a typical
Typical. So what are my friend Nandlal is saying? What is it? Correct or incorrect? So Nandlal, his master who has sent the questions, is having some other opinion. So is periosteal reaction common in chondrosarcoma? What do you think?
Sir, I think what my thought process was that it might be an osteochondroma which underwent malignant transformation to chondrosarcoma.
So osteochondroma can convert into chondrosarcoma. Can osteochondroma convert into osteosarcoma? Any type you know? Osteochondroma converted into osteosarcoma. A specific type of osteosarcoma. Chondroblastic osteosarcoma. Can it get converted to that type? Chondroblastic osteosarcoma. Here, the thing was there was periosteal reaction, what I said. There is some periosteal reaction, so that is not common in chondrosarcoma. So it's A. The answer is A here. It's osteosarcoma. So bit tough.
It's very tough.
Yeah, it's a bit tough. I agree with you all that it's not that easy. So that was one hint I gave, that periosteal reaction. I said it's a periosteal reaction. We go for the last question. So here there is a lesion, soft tissue lesion, again, and patellar region, incision of the patella, and these are the options here.
Sir, option B, periosteal ganglionic cyst.
So you think it's a cyst, and what is the opinion of other our friends? What do you think? It's a cyst or a sinus
Maybe bursitis, I think. Maybe.
So these tumors are a bit tough again, Aditya has given his answer as B, but this is a bit tough. That soft tissue swelling. And what do you think?
No
Yes,
comments, sir.
what do you think? It's difficult.
Yes, it is difficult.
Yeah, on MRI, soft tissue swelling, to characterize the soft tissue swelling on MRI is very difficult. You always need a biopsy. The take home message is any tumor you need to biopsy, barring few. So 99% tumor requires biopsy. Despite you're very much confident on X-ray, MRI, any method you choose, still you require biopsy. So for this case also you require biopsy and yeah, Nanlal, it's correct. Yeah, so my friend Nanlal is saying yeah, it's correct answer. So we have plus 10 marks here. So Aditya goes to how many marks now? It's 20. So Hitesh needs to catch up now. All others are doing good. So lastly, we have Abhishek. Yeah, Abhishek, ready?
Yes, sir.
Again, a very big question, but important is few words here. One is a young girl with a lesion in femur fracture, and she has multiple bone pains. There is a skin sign that is cafe au lait spot. And what is your best differential here? It's Olliers disease, Maffucci syndrome, multiple myeloma, Ewing sarcoma, and McNutt-Albright syndrome. So what do you think here?
So it's E, McCune-Albright syndrome.
McCune-Albright syndrome. So very classical, very common question as an exam. So you are correct here. It's plus 10 marks. So it's plus 10, Kirji. We go to next question. Yeah, Kirji, we go to next question.
Yes, sir.
Yeah. Yeah, so this is the, so we need to add 10 marks for Abhishek. So that will get added. And this is the question for you. The following chromosomal translocation and association is not true. So important, it is not true, incorrect. So Ewing sarcoma 1122, Samuel sarcoma X18, clear cell sarcoma 1222, myxoid liposarcoma 1218, and chondrosarcoma 922. So which is incorrect? So if you read previous questions, there was something hint that we have seen these translocations. At least 2 or 3 translocations we have seen in our previous questions. So take your time, read the question, the answers, which is not true. It's incorrect. Ewing sarcoma, Samuel sarcoma, clear cell sarcoma, myxoid liposarcoma, and chondrosarcoma. You think it's difficult or tough question, you can pass. You can give your answer. You just think and tell your answer. You're doing good. First answer was correct. So
I think it's myxoid liposarcoma.
So you think it's myxoid liposarcoma. So 1122 is for Ewing sarcoma. You know that answer. Ewing sarcoma, what is your translocation? This is very common. 1122. Samuel sarcoma also is correct. Clear cell is also correct. So the answer is D. It's correct answer. So nice. So you have given second correct answer. So we go to the third question.
Yes, sir.
This is your third question regarding chondromyxoid fibroma, CMF. What is true? Occurs through third decade of life, a common tumor. It is located in humerus, presents as a sclerotic diaphyseal lesion, and presents with periosteal reaction. So which is true? It's a common tumor or uncommon tumor? It occurs in which age group? What is the location? How it looks radiologically? And some radiological feature like periosteal reaction. So what do you think, Abhishek?
So I would like to go with A. Occurs first.
Do you think that it is more common in this age group? So what is the opinion of our house, that everyone agrees with him, Abhishek? Yeah, Abhish, what do you think?
I will also go with A.
Yes. So any other opinion, or it's A or for all? Yes, Nitish, what do you think?
Sir, A or E, I am confused.
E तो मुश्किल है, तो A होगा. So A is correct answer. So nice, Abhishek, you gave correct answer. So we go for fourth question now. So fourth question, again a radiograph of a patient who looks to be skeletally mature. Physis looks closed. Tumor involving the distal femur, metaphysis and diaphysis, which is sclerotic, and there is some periosteal reaction of some classical types here. So the differentials, one is telangiectatic osteosarcoma, second is conventional osteosarcoma, third is paraosteal osteosarcoma, and fourth is none of the above. So what do you think it is? Some type of osteosarcoma or any other tumor like chondrosarcoma? Means D.
Sir, it's osteosarcoma. It has sunburst appearance. I would like to go with telangiectatic osteosarcoma.
Which type you want to say? Telangiectatic, conventional, paraosteal?
Sir, telangiectatic.
You want to go? अभी तो हमने डिस्कस किया telangiectatic में क्या होता है? Pathological fracture होता है. So why pathological fracture occurs in that type? Any reason? Yeah, Ravi, what is the reason that why it gets more fractured? Telangiectatic type.
Because that's an aggressive internal bleeding.
Aggressive one thing, and
fills
second it is osteolytic or sclerotic.
Osteolytic.
Osteolytic.
Blood filled spaces.
So that's why more fracture. So how this lesion looks to you? Osteosclerotic or lytic?
Sclerotic.
How is the content? रुई जैसा है, cotton जैसा है. नवीन सर ने दिखाया ना. So this is conventional osteosarcoma. So -5 here. Just read the X-ray. Take your time. We have formulated a very easy method: A, B, C, D, E, F, and Z. A to Z. A age, B bone, B content, C characteristic, D distribution, E exterior, F fracture, and Z zone of transition. That is subjective method. We have made a scoring system also. Score less than 3, benign. Score more than 3, malignant. So here it's score up to 5 something. So it's classical of osteosarcoma, which is of conventional type. So we go to last question for you. So again, a radiograph for you. A lesion into skull. This is a very classical radiograph available everywhere. Lesion involving the skull bone, which is having lesions, multiple lesions, which are of punched out type or moth-eaten type. And the differential diagnosis can be in tumor like parathyroid adenoma, multiple myeloma, metastasis, and none of the above. So none of the above, it can be chondrosarcoma, osteosarcoma, or any other tumor, Ewing sarcoma, we can say. So read the X-ray again, very classical, common punched out lesions.
Sir, it's B, multiple myeloma.
You think it's multiple myeloma. So you are correct here. So it's plus 10 marks here. So nice. So everyone has done very nicely in the first round. So we have next round, which is case-based round. So that will be the third round. So final marks here, highest marks getter is Ravi, and all others are just nearby. So all needs to catch him up and we need very tough fighting here. So next is a case-based round. So we give cases, and for one participant, one case. If he gives correct answer, it's plus 30. So all others can catch with another person very easily. It's plus 30. If he gives incorrect, it's only minus 10. But if you give correct answer, you get plus 30. So very important, good number of marks. And the question can be passed here. And if the next person gives the answer correctly, then he gets 15 marks. And if he also gives incorrect answer, he reduces his marks by 5 number. And here we will not go from A to F. Here we go from F to A. So first we will ask Abhishek, then Aditya, then Ravi, Kshitij, Somak, and Tabish. So the first question will be asked to Abhishek. If he gives the correct answer, he gets plus 30. Then we ask next question to Aditya. If he gives correct answer, he gets plus 30. If next question to Ravi, he gives correct answer, plus 30. If the question goes to Kshitij, he gives correct answer, plus 30. If it goes to Somak, and Somak says he don't know the answer, and question gets passed to Tabish, and if Tabish gives the correct answer, he gets plus 15. Tabish gives incorrect answer, it reduces his marks by 5. So that is the sequence. So from F we go to A, correct answer plus 30, incorrect answer minus 15. If the question is passed to the next person, then plus 15. If he gives incorrect answer, minus 5. So any queries here in this round? So it's a clinical round, clinical case based. So it's a case based. Yes, any query? Yeah, Tirji. Yes. So it's Abhishek's question, and Abhishek says he doesn't know the answer. So okay, so everyone has, that is good thing. So you need to be alert. किसी को सोना अलाउड नहीं है कि अभिषेक को पूछ रहे और बाकी लोग सो गए, ऐसा अलाउड नहीं है. So Kshitij, you can catch up this now.
Can you please repeat? We are basically, this round is not clear.
Yes. देखो पहले अभिषेक को सवाल पूछा,
Yes, sir.
अभिषेक ने आंसर नहीं दिया.
Suppose इसने सर आंसर दे दिया, suppose इसने आंसर दे दिया तो बस it is over and he is right.
हाँ, उसने आंसर दे दिया तो फिर तो खत्म हो गया ना. उसने सही दिया या गलत दिया, कुछ एक होगा.
Okay, sir. Then अगर इसने नहीं दी,
then he minus 15. Minus 15. If he says pass, then all others need to be alert. वो पास बोलने की राह देखना है. यदि वो बोला पास तो सबने जल्दी.
How will we indicate if the passing question comes to us?
हाँ.
How will we indicate?
क्या बोल रहे हो?
We should be writing yes or something.
Yes. जो भी y डाल देना, आप जो भी जल्दी लिख सकते हो y डाल देना. Y is easy to type.
Okay.
Yeah. So the rule is okay with everyone.
So any time limit for the question?
Yeah, Tabish. Rule is okay.
yes, sir.
Yeah.
So it is suppose the
So everyone gets one question. Everyone gets one question. So we start first with Abhishek. Then we go with Aditya. So there are 6 contestants and 6 questions. Yeah. 6 contestants and 6 questions are there. So if the question is passed, then you have chance to get more marks here. If you lose it, then it's a bit bad. Minus 10 marks. So can we start with Abhishek first? First question for Abhishek. Yeah. Yeah, so a case of 50 years old female to the outdoor department with the chief complaints of pain and swelling around her left wrist. So a skeletally mature person, 50 years lady, presents to the OPD with chief complaints of pain and swelling of bit long duration, means 1 year. Her clinical picture and MRI imagings are there. And what do you think should be the next line of management? So we have seen the patient in our OPD. We got an X-ray done for the patient. we have done a MRI, and we are showing here you the clinical picture of the patient and a MRI. And what is the next management? So this is the patient, long history, long standing, very important, long standing history. Lesion involving the wrist area, which bone is involved here, and what is the differential based on the history and MRI, and what should be the next treatment for her. So we will have the treatment options available. You have seen the clinical picture? Yeah, Abhishek?
Yes, sir.
This is the clinical picture, some swelling into the ulnar region. The tumor most probably arising from ulna of long duration. And this was the MRI done, and we did the treatment for this patient. So we can go to the answers.
Yes, sir.
It's a recent case we operated just 2 or 3 weeks back. Satirji, we can go for the answers. So we don't have the answers here. So what do you think? What can be the management for this case? What do you think? What is your differential diagnosis here? And how will you proceed with this case? So do you think it's benign or malignant? Then what is your treatment option here? And what you think can be the final line of treatment for this patient? So do you think it's benign or malignant?
So it's benign because long duration.
So you think it's benign tumor? The next, what is your differential? It's long-standing tumor, you think?
So it can be a giant cell tumor.
You think it can be a giant cell tumor? Next, what do you want to do for this patient?
I would like to go for extended curettage with bone grafting.
Directly, without any other investigations.
So first I will do biopsy, and then I will go for extended curettage and bone grafting.
So what others think that? Is he correct?
No, sir.
So yeah, Tavish, what do you think? Is he correct or incorrect?
Yes, sir, incorrect. We need to first perform a bone biopsy.
So is his differential is correct? It's benign tumor?
It is a locally advanced disease. We
Locally
cannot say it is
advanced
benign.
disease.
It is
Yeah.
a locally aggressive lesion.
Yeah.
In a skeletally mature female. So we need to basically investigate, and we have to go for a biopsy. We have not to touch this lesion without a biopsy.
Yeah. So Ravi, what do you think it can be? Giant cell tumor, can it be? It's a long-standing history.
Maybe, but it doesn't looks like giant cell tumor.
So first step is always a biopsy. So
Yes,
Abhishek
biopsy is the first.
didn't say that. So biopsy is required for this case. Then after biopsy, what surgery you think? Yeah, Aditya, what surgery can be done for this patient? It's a giant cell tumor. Can you do curettage here?
So distal ulna might be resected. Should be resected.
So is it curatable lesion? Yeah, so much.
Sir, it doesn't.
No,
seem
sir.
like
It's an
No,
expendable
Abhishek,
bone.
It is not
doesn't
a,
look
it's not a
anything
curable
curatable
lesion.
here. It's totally destroyed. Nothing is there.
We have to go for
This-
en masse, yes, en
And
masse
mass
excision.
resection. So for this
En masse
case, we took first control of the ulnar artery. We dissected the ulnar nerve. We dissected the median nerve. Then we had taken a proximal cut, distal cut. We need to take a big skin incision here. A Y-shaped incision was taken. We removed some part of the skin which was going up to where the tumor was extending. So good amount of skin was excised. So it was a giant cell tumor. We didn't treat with anything extra. Denosumab, zoledonic acid was not given. It was resected. So It's not a correct answer in the line of management. You reached something in the diagnosis, but your management plan was incorrect. So here it's a bit difficult because these tumors are not that common, you must have seen. But few tumors, distal and ulna and proximal fibula, you can resect it, no need of during curettage in these two tumors. So we can't give your marks to you because it was not the correct line of management. So we go next to Aditya. So next case for Aditya. So a 45 years male presented to OPD with complaint of pain and swelling around left thigh for 6 months. So a elderly person, not elderly, but it's a middle-aged person, 45 years with pain and swelling in left thigh for 6 months. His radiograph and MRI is given below. And again, you need to tell what is the best possible line of management. So your differentials, what is your diagnosis, you think, and how will you proceed for this patient? So can we show the radiograph and imaging? So skeletally mature individual, lesion involving the femur, metaphysis and diaphysis, which looks to be of which type. Here we can't tell you the something more on the radiograph. MRI is here and it shows lesion involving the femur. So benign or malignant, best possible differential, and you further line of management. So take your time, take 30 seconds, read the X-ray, read the MRI, get something in your mind that how will you proceed for this patient, and the final line of treatment if you think it's that type of tumor.
Sir, there is a short history of 6 months.
Yeah.
So it might be a malignant tumor. Then there is some what seems to like be an industrial escalloping.
Yeah.
With some calcification maybe inside the matrix in the X-ray.
Yes.
And there is also extra compartmental spread, what seems like to be spreading outside the femur also in the soft tissue. So my first step would be to confirm the diagnosis of by biopsy. My first.
So what is your differential, benign or malignant, do you think?
Some malignant.
Malignant. So malignant. Anything specific you want to say differential?
Sir, chondrosarcoma would be my first.
So one differential is you want to say chondrosarcoma. Yes. Next, what is your line of management then?
Sir, next I would like to take a biopsy of the tumor.
Yeah. Yes.
And if it comes out to be chondrosarcoma, then since chondrosarcoma does not respond to radiotherapy or chemotherapy, I'll go to wide resection. But in this case, wide resection will not leave any tibia, any femur. So maybe, sir, maybe a hip disarticulation.
Yeah.
Or maybe a full femur prosthesis, like total femur prosthesis.
Yeah.
After that.
Yeah.
So
what Aditya said, you agree with him? So his differential is chondrosarcoma in a gentleman who is 45 years. Radiologically, it looks to be him a chondrosarcoma.
And sir, additionally, to look for any metastasis.
You do the metastatic workup. Yeah, you do metastatic. Yes, Sumak. What points he has, and you think all are correct or something is missing from his side?
In the management part, sir, I would like to first do a staging. So
he has said that metastatic workup, PET CT scan or CT thorax bone scan can be done. So that is correct. So anything you think is correct or?
I would like to first see whether the limb is salvageable or not by the 3
So he has said both the options. One is hip disart and total femur. Both are good options. Yeah, Tabish, you think it's correct for 30 marks?
So I will
Yeah, Tabish?
So I will see for other differentials also, because it is not a typical location for a chondrosarcoma.
So you can see the other differentials also. Yeah. So it can be
Definitely.
osteosarcoma.
Yes. It can be.
Yes, osteosarcoma above 40 is common, but yes, that can be one
Uncommon. It
differential.
can be an osteosarcoma also.
Yeah, it can be one differential. But here, what is classical on MRI? You can see something.
Soft tissue. There is. Yes, sir.
No, soft tissue is okay. The marrow.
Marrow edema.
Yes, sir. Marrow.
Marrow
Marrow
extent.
edema.
So radiologically, it doesn't look that going down, but on MRI, it's going up to distal of the end of the femur.
Yes, sir. It can.
Very classical of chondrosarcoma here. Very classical.
Yes, sir.
So Aditya is perfectly correct. So treatment option here, one can be hip discharge, second can be total femur. We did third, another option which is not that common option. So we
Rotation
seated
plan.
the bone. We took a cut few centimeters above the knee joint with good wide margins. So a cut was taken, what we showed in the our 3D printing case. So we took a cut just above the knee joint, few centimeters above. Removed the bone, send it to radiotherapy. ECRT was done, extracorporeal radiotherapy. Then the neck was cut, and then a long stem bipolar was placed. So it is an osteoarticular autograft. Osteoarticular autograft. And two plates were placed, one is lateral and one is medial. So that is some newer type of treatment option that you save patient's own knee joint because you require a total femur. So we saved patient's own knee joint by saving his own knee. We need to replace the neck of the femur, so we did a long stem bipolar. So Aditya was very much correct. Yeah, so it's plus 30 marks for him. Nice, Aditya. You have given very correctly the answers.
Okay.
So next we go to Ravi.
Yes, sir.
Yeah, Ravi, you are ready. So it's
Yes.
a 22 years lady with pain and swelling around the knee joint for 3 months duration. So it's a young lady with pain around the knee, pain and swelling for 3 months duration. So we did clinical examination, X-ray was done, MRI was done. And what do you think the line of management should be there for this case? So take your time, read the imaging, formulate a treatment plan, and just tell everyone what you think. Yeah, Ravi?
Yes, sir.
Yes, Neerji, options can we show for him? The imaging? So it's a young lady with pain of short duration history. Some pain, just minor swelling, not significant. This was a X-ray and this was a MRI. Tumor common in young age group, around the joints. Very classical locations.
Yes, sir. So it looks like giant cell tumor.
Yeah.
Of the distal femur.
Do you think it's a benign bone tumor and your differential will be more of a giant cell tumor? What do you want to say? Yes. So
Yes, sir.
after your differential, what we have done the X-ray MRI. What next you want to do for her?
We can go for biopsy for the
No, we
confirmatory
can go.
diagnosis.
No, we need to go or we don't need to go. We can go नहीं. करना चाहिए कि नहीं करना चाहिए? X-ray में तो GCT लग रहा है तो आप क्या करोगे? We'll do biopsy. What we
Yes,
have
sir,
learned
we
in the 2 lectures, we need to do biopsy. So you say
Yes, sir.
you need to do biopsy and you prove it as giant cell tumor. Then what is
Then
your next line of management?
Then we'll go for, sir, Curitas and with bone grafting or for a stabilization, we can do lateral distal femur plating also.
Yes. So you think it's a benign bone tumor? It's a giant cell tumor.
Yes.
Need to do biopsy, prove it as a giant cell tumor, and surgery will be curettage. And you want to put a bone graft and you want to put a plate. So Abhishek, what do you think?
Bone cement.
Yeah, bone cement can be one option. Yeah, so multiple options can be. Yeah, so Abhishek, what do you think is correct or you want to differ with the something other thing?
I think he's correct.
He is correct. Yes. Yes. Yes, Shitish, what do you think?
Yes, sir, I'll go with him. He is correct.
He is correct. So radiologically very classical epiphyseal metaphyseal lesion. extending to the articular cartilage. Borders well defined here, and on MRI, it's half of the cortex is involved. So you can go with curettage, bone cement, and a plate if required. So Ravi is correct in his answer. So we can give him 30 marks here. So nice, Ravi. So next we go to Kshitij. Kshitij, take your time, read the imaging. We need your plus 30 from you to catch up with others. So 15 years girl with pain and swelling in her shoulder area for 3 months, some limited range of movement, and we are given again X-ray and MRI. Young girl, short duration history, pain swelling, some limited range of movement. So what do you think? Again, benign, malignant, what your treatment plan? And so this was the thing. This is a bit easy now. You have seen the X-ray in previous part. So Dr. Nandlal has helped you here to get 30 marks.
So short duration and a young female, it would be a malignant lesion.
Yeah.
And
Actually, you can say you know the answer. Just few slides back, we have received this X-ray also.
yes, so periosteal reaction can be seen for osteosarcoma.
Yeah. MRI was done. So what
Yes,
next we want to do for her? Take for
Sir,
surgery.
in order to confirm, we'll go for biopsy first.
Yes, so we have done a biopsy and it's osteosarcoma. And then what is the treatment? Next day post for surgery? Or wait for something else?
Uh,
So you have done the biopsy. So for osteosarcoma, what is the treatment? What you do? We have discussed something for chondrosarcoma.
yes.
Osteosarcoma is same or something different?
So we can go for chemotherapy and then wide resection.
Yes.
And sir, as it is extensively involving the humerus, so proximal humerus, so I think so that we'll have to go for amputation of the 4/4 amputation.
Yes. So Ravi, what do you think? Kshitij is correct or incorrect? It's benign or malignant. What do you think? It's malignant. He said it's osteosarcoma. Yeah, he said it's biopsy required, and he will give chemotherapy, and then he'll do surgery. So, what do you think? He has,
We have to stage the.
yeah,
for
so
staging
staging
the
workup, yes.
treatment.
So he need one staging line. So that is okay. That. So what do you think? He's correct. Yeah, so we can have.
Resect the tumor, neoadjuvant chemotherapy.
Yeah,
then
so neoadjuvant
resection,
chemotherapy.
we can.
Yeah, so he said chemotherapy before
And
surgery. Yeah, so he said chemotherapy before surgery, so that is neoadjuvant. So that is understood. So it's 30 marks for Kshitij now. Nice, Kshitij. So next we go to Somak. So, yeah, Tirji, question for Somak. So it's a 21 years gentleman with pain and swelling around right little finger. So now from lower limb, we are coming to upper limb, from shoulder to hand. So young gentleman, pain and swelling, 4 months in a little finger. So we see the imaging and what we have for you, radiograph and imaging. Just Tirji, we can show the options. Imaging, X-ray and MRI for you. So some tumor in the little finger, which looks to be involving the fifth finger. Involving the bone here, bone and soft tissue. So this is a bit difficult. It's not that easy like Kshitij. Tumor involving the humerus. So it's fifth finger, some lesion, X-ray done, MRI done, few months duration history, some pain and swelling. And the MRIs are very classical.
Based on the history, sir, and the MRI in the second picture, it is hyperintense lesion, most likely to be a fluid level, fluid sign is seen in the MRI.
Do you think benign or malignant? You think it is, and what is the treatment plan then?
So the lesion is osteolytic. With in the X-ray there is sclerosis around the lesion, sir. So it's likely to be a benign tumor, sir.
Yeah. So you think it's a benign tumor, and what next you will do for him?
So, sir, it's likely to be an aggressive benign tumor. So, I would like to do a biopsy first to confirm my diagnosis.
You will do the biopsy, and you get a histopath, something of a benign bone tumor. And what is your next treatment option?
Sir, in biopsy, if it comes out to be aneurysmal bone cyst.
Yeah.
So then, our line of management could be we can do curettage and bone grafting for the lesion.
Yes.
Or based on Kapana's, if it comes out to be aneurysmal bone cyst, we can do the Kapana's grading, and based on Kapana's grading, we can see if we can go for a trial of aspiration with polydocanol injection first, and then after
sclerosant can be given polydocanol.
After sclerosant application, we can go for if the lesion size decreases, we can further go for bone curettage and bone grafting.
Okay. So Abhishek, what do you think? It's benign or malignant?
This is a benign.
Looks benign. So looks benign to everyone.
But locally aggressive.
So locally aggressive, you can say everyone agrees it's a benign bone tumor. This is a bit difficult. It's not an easy question. So it's a benign bone tumor, everyone agrees, and the biopsy was done. So we will give the marks to Somak. It's a tough question. So the histopath was not aneurysmal bone cyst. It was a schwannoma, intraosseous schwannoma. So it was a soft tissue tumor going into a bone, and we excised the tumor, and there was a small defect. The defect we didn't fill at present. So one option we can fill it with a bone graft, and it was a intraosseous schwannoma. So it's very difficult. As a hand surgeon, one of our colleagues, we showed this case, so it was difficult for him also. It's not that easy case. So we give 30 marks to Somak now. So your approach should be correct. Differentials can be multiple. So if your approach is correct, then you can reach the proper diagnosis here. And if you think it's something mismatch in your diagnosis, you can do repeat biopsy. So that can be done. So we go to our last contestant, Kabish, for this round. So third round, 18 years gentleman with pain and swelling over the thigh region for 4 months, and his MRI and X-ray was done. So what should be the line of management for him? So Abhish, you can get your 30 marks here. You have done very nicely. So we have a tough fight then. 75, 80 and 65.
Okay.
So this is a bit easy case for you. So lesion in a young boy,
Yes,
femur. Lesion in the femur,
young adult, age 18.
and this was X-ray and MRI done.
Yes, sir. There is a.
Take your time, read the X-ray and MRI, think your line of management, and then tell. Take your time, half minutes time, no problem. After this round, we have 2 next rounds. So that will be a bit smaller so that we can have good.
There is a, yes,
yeah, you can tell the answer.
Yes, sir. There is a sclerotic lesion, or we can say plastic lesion, which appears in the diaphysis of the femur.
Yeah.
Age is at 18. And the MRI is on radiographs also, we can see a soft tissue component. Then going to the MRIs, there is a soft tissue component. We can see both on the coronal as well as the this axial sections that is involving the bone as well as the soft tissue.
Yeah.
Age is 18.
Yeah.
So yeah, I will. So the possibility is basically he is having a malignant tumor.
Yeah. So you think it's a malignant tumor? Yeah.
Yes, sir. Yes, I think it is a malignant tumor. We can see the bone marrow edema on T2. It is basically involving from the lesser trochanter up to the distal field.
Yes.
So it is likely a malignant lesion. I will go with firstly a staging protocol. I will go
Okay,
with
so you think which tumor it can be?
yes, sir.
X-ray?
Age-wise and the radiologically wise, I have to go with certain differentials.
Yeah.
Yes, so my differentials will be Ewing's and osteosarcoma.
So first, what do you want to say, wings or osteo? So no problem. You say
Ewing's and osteosarcoma, and
both you want to keep, no problem for that. So you'll do the biopsy, you'll do the staging workup,
yes, yes.
and
I
depending on
will
the
do the
histopathology,
yes,
you'll
a chest, abdomen, pelvis, CT.
Yeah.
That is the basic I will do. Then I will go for then I will just go for a consultation with the oncosurgeon, and I will plan a biopsy for the same.
Yeah. So you've done the biopsy. It's osteosarcoma, Ewing sarcoma. What after that? What will you do? You've done the
Yes, sir.
staging.
Yes, sir. In both the cases, the protocol is same. We have to go for neoadjuvant chemo.
Yes. So both you require chemotherapy.
Yes, sir. Neoadjuvant chemo
After
followed
that,
by
you will do surgery for it.
yes, I will see the how the tumor has behaved
Yeah.
with the neoadjuvant, and with the then almost we have to plan for a definitive surgery for this patient.
Yes. Yes. So yeah, Aditya, what do you think? Tabish is correct. His approach is correct.
Yes, sir. And repeat MRI can be done after the neoadjuvant chemotherapy.
Yes,
To assess
repeat
the
MRI
extent
can
of the
be done.
lesion.
If required, you can do staging workup also. So that can be done. So your approach should be important. What he said, imaging, MRI, biopsy, staging workup, chemotherapy before surgery, surgery, then chemotherapy, limb salvage, amputation, multiple reconstruction option. That depends on the surgeon and the what things are there. But your approach should be very much correct, and his Tabish's approach is very much correct. So it's 30 marks for Tabish also. So congratulations, Tabish.
Yes.
So it's tough fight between Ravi, Somak, Aditya, and Tabish. Our two contestants needs to add some marks more here. Abhishek and Kshitij. Yeah.
Yes.
So you can catch up, no problem for us. So for next round, round 4, that will be buzzer round. So my colleague Dr. Nandlal will be there. So he will say all the rules, and so next is Dr. Nandlal with us. So he will tell all the questions here.
Yeah, good evening, everyone. Myself, Dr. Nandlal. I am working as a fellow in GCRI in orthopedic oncology, and Dr. Abhijit Saluke sir is my mentor. And I am very grateful to sir that he has given me the opportunity to conduct the quiz. And for the round 4, here are the rules. There will be 5 questions, and it is a basically buzzer round. So the first one candidate who has said yes or who has raised the hand will be given the chance to answer the question. And for the right question, he will be given 30 marks. And if he has not given the right answer and the question has been passed to another people and they have given the right answer, they will be given as the marks. And even if the second or third passing is done and they have not given the right answer, so no negative marking will be there.
So not clear, sir. For the
It's
first
not clear.
passing,
Yes, in the buzzer round, the person who has first raised the hand will be given first chance to speak the answer. And if the answer is right, he will be given 30 marks. Okay. And for the wrong question, minus 10 will be there. And then after, the question can be passed to another people. Okay. Clear?
How will the question be passed to other people based on what?
Yes, yes. Yes, yes. Yes. Yes, yes, yes.
So what we have to type? Yes. Okay. And I will be just negative marking.
For
So
passing.
for passing,
No, suppose I type yes and then I say passed. Question is passed. Okay. Okay.
so no sequence here means a single person can answer all the six question. Okay.
And sir, please clear that only Y will be valid or whole yes, Y, yes.
Yes, Teji, question number 1 to be displayed. In this question, you have to do a spot diagnosis only. Okay, Dr. Aditya has responded first.
Should I give the answer?
Yes, yes.
Conventional osteosarcoma.
No, conventional osteosarcoma is not the correct answer for this question. And then the second chance will be given to Dr. Ravi Ranjan.
Sir, Ewing sarcoma.
Yes, Ewing sarcoma is the correct answer for this radiograph. You can see a laminated periosteal reaction or a onion peel appearance. Not so characteristic, but osteosarcoma, you can see a characteristic sunburst appearance, which is not seen in this radiograph. So for me, the right answer is Ewing sarcoma. Teji, second round, second question. Yes, Dr. Tabish has responded first.
Yes, sir. There's not age wage, but it's just spot diagnosis.
Yes,
Age
sir.
wage, you don't have to.
No, just the spot diagnosis only.
Okay, it's an enchondroma.
Okay, and some other?
Sorry.
Enchondroma is not the right answer in this question. Anyone else?
Chondroblastoma.
Dr. Aditya will get the chance now.
Sir, chondroblastoma will be minus.
Chondroblastoma?
Blastoma.
No, chondroblastoma is not the right answer in this case. Dr. Abhishek will get the chance.
Sir, aneurysmal bone cyst.
No, aneurysmal bone cyst is not the right. Next.
Sir, only two passing was okay.
Okay. So the right answer is chondrosarcoma. You can see a bit of calcification in the background in the matrix, which we were talking about the chondroblastic content. So it was a bit difficult for us also to pick on the radiograph, and it is a biopsy proven chondrosarcoma of the proximal humerus. So next question. Dr. Tabish has responded first.
Osteoma.
Yeah, your diagnosis is absolutely correct. Characteristic nidus seen by a sclerotic rim of bone on the CT scan. Next question. Okay.
Yes, sir. Chondroblastoma.
Yes, spot diagnosis is very right. Chondroblastoma, seen mostly in the immature skeleton along with a epiphyseal involvement. Next question, Teji. Next question. Yes, yes. Yes. What will be the spot diagnosis in this case? MRI of a distal wrist along with a distal ulna is given. Dr. Abhishek has responded first, I guess.
Chondrosarcoma.
No, chondrosarcoma is not the right answer here. Next one, Aditya Patni has given that response. Yes.
Giant cell tumor.
You are very much near, but not typical of the giant cell tumor. You can see, and next one also.
Aneurysmal bone cyst, sir.
Yeah.
It's my turn.
Yes, yes. Dr. Tabish has given a right answer. It is an aneurysmal bone cyst. You can see a multiple fluid filled levels, not so characteristic, but you can see a multiple patches along with a fibrous septa and multiple fluid levels. And next, okay, the 5 questions were in the round. Dr. Tabish has given, I think, 3 answers in the round 4 correctly. And now the last round will be a rapid fire round, which will be conducted by Dr. Abhijit Saluke, sir.
Continue.
Okay. So I will continue the round 5th. And in the round 5th, 5 questions for each contestant in 1 minute. We will be given, and skipping the questions will not be allowed in this round. Right answer, for every right answer, 20 marks will be given to each contestant.
So no negative marks.
No.
If it is a right answer, we'll give 20 marks for each question.
Yes, and there will be a no negative marks.
Okay, only time.
Duration.
If we, I mean, it's only 1 minute is for one question or a total of 5 questions?
Total 5 questions, only 1 minute. It will be a rapid fire round.
Okay, there's no negative marking.
No.
Is it a rapid fire also? Is it also a rapid fire, or is it for individual people? Suppose I cannot answer the other contestants' questions.
No.
No
You
person.
can only skip the question. No participant will be allowed to answer your questions.
Okay.
Teji, can we?
We have to type the answer. We have to type the answer or verbally.
You just need to give the answer. No need to type the answer.
Okay.
एक बार पूछो सारे क्वेश्चन ये रूल्स समझ गए सबको?
Yes, sir.
So everyone is clear with the rules.
It will
be so 5 questions for each contestant. That is one thing. Second is maximum 1 minute. So in 1 minute you need to answer. Maximum you can give 5 answers, 5 questions for one person. So skipping is allowed. You can say just skip, and then you go to the next question so that you save time and earn more marks. Right answer will give you 20 marks, and here there is no negative marking.
And sir, if time is left, then can we go back to the questions we skipped?
Difficult in 1 minute. I don't think so. There will be time to go back. If possible, we will go. No problem for us. But you can. But it will be a bit difficult. I think so for both of us. For us also and you also. That in 1 minute, how much you will read and how much you will answer. But if possible, we will go. No problem for us. No problem. Yeah. So all questions, all rules are clear, because this is important. See, the marks are very close of
Dr. Ravi
3 people. One is Tabish, second is Ravi, and Somak is on 70. So these 3 people can catch more faster, and others also can catch, because here there are 100 marks. So if someone goes wrong here, then others can catch him. Yeah. No problem. So no problem for us. So it's 135, 170. No problem. So
start from A to F or F to A, the questions.
A to F इसमें कोई problem नहीं इसमें सबके लिए सेम ही रहने वाला है, सब सारे क्वेश्चन सेम ही है इसमें, A to F to A
And we have to just this verbally answer them.
क्या बोल रहे हैं?
Yes, you have to give verbally answer only.
जस्ट वर्बली आपको आंसर बोलना है, समझो रेडियोग्राफ है कि जायंट सेल ट्यूमर एन्यूरिज्मल बोन सिस्ट से जो भी है तो जल्दी जल्दी आप बोलोगे, यू गेट मोर मार्क्स हियर. So all are ready. This is last round. So it is really great that you have taken your time and you are continuously attached with the quiz, because it's for bone tumors. This was our first attempt, and we'll take this to next level next time. So on next conference also. So can we start here? Yeah.
Yes, sir. Okay, sir.
So we start with Tabish then. Yeah. Histology of the lesion shows low grade.
Sir, I will read it. Sir, I will read it myself.
Yeah, you can answer you.
Skip.
Next.
Spine.
Most common skeletal mets.
Spine. Spine.
Next. Most common second metastatic disease.
Bone.
Next. A chordoma is most likely found in which bone?
Sacrum.
Next. Which of the following statement is not true for non-ossifying fibroma? Yeah, fast.
D.
Yeah, B. He has given B.
No,
yeah.
no, sir, not B.
हाँ, D. क्या बोला?
Sorry, sir.
कौन सा आंसर बोला?
D.
दिल्ली का D. So you have 3 correct answers and 1 skip. One wrong answer. So there is no negative marking. So you have 3 correct answers. So 60 marks. So this is the trick here, that if you don't know the answer, pass it. Go to next question. No, go to next question. Go to next question. So Tabish has done very nicely. So others have still chance to catch him. 5 correct answer and Ravi can reach to 200. Yeah. So can we go to second contestant? Yeah. Somok, you are ready?
Yes, sir.
So 3, 2, and 1. We can start. Most common tumor with metastasis to bone in decreasing order.
Sir, option B, breast, prostate, lungs.
Yeah. Next question. Enchondromas may commonly occur in which of the following except femur, humerus, femur, phalanx, and pelvis? Enchondroma except. Skip. Next. Which of the following soft tissue sarcoma is most common in children? Pediatric soft tissue sarcoma, most common. Epithelioid rhabdomyosarcoma, rhabdomyosarcoma. B. Next. So which of the following statement is false for osteosarcoma? Which is false for osteosarcoma? Fast.
Sir, C, chondroid matrix.
B. Next. Hereditary multiple exostosis. Which part of the growth plate is affected? Fast. Oh, time. Soumik, कोई बात नहीं. So Soumik has given 2 correct answers and 1 wrong answer. Wrong के लिए mark negative नहीं है. So Soumik gets 40 points. So Soumik reaches 110. No problem, Soumik. Played well. So we go to next. Kshitij.
Yes.
Kshitij, you are ready? So you can
Sir,
just
can you
get
please
100 marks.
Yeah, sir, can you please read it? My resolution is not good. Internet is
No
slow.
problem. We'll read for you, but it will take more time. No, so it will eat your time bit more. No problem. We'll read the thing for you.
Thank you.
So can we start for Somik? 3, 2, 1. Yeah. The following are benign tumors except adamantinoma, giant cell tumor, chondroblastoma, aneurysmal bone cyst, and osteochondroma. Which is not a benign bone tumor?
Adamantinoma, sir.
A. Next, which following statement is false for fibrous dysplasia? Developmental abnormality that can be mono or polyostotic, ground glass appearance associated with GS alpha protein, associated with cafe au lait spot, fibrous dysplasia heals with fibrosis.
Sir, F, last option.
Last E. Next. Preoperative embolization to decrease blood loss intraoperatively is used for which tumor? Metastatic renal cell, osteosarcoma, osteoblastoma, enchondroma, osteoblastoma.
So,
Fast.
osteosarcoma, sir.
Osteosarcoma. B. Fourth question. What process most clearly resembles radiographic and histological presentation of multicentric giant cell tumor? Paget's, Campanacci, Olius, transient, osteoporosis, or hyperparathyroidism? No problem. Time is up, but still you can answer.
Sir, So can you repeat the options because it is not clear to me.
Paget's, Campanacci, Olius, osteoporosis, and hyperparathyroidism.
Sir, hyperparathyroidism.
So take last question. Just till we can finish it. Last question. Aneurysmal bone cyst of spine is most common in which following region? ABC of spine. Lumbar, lower lumbar, lower thoracic, upper thoracic, and sacral.
So I am guessing it lumbar.
Okay. So how many correct? नहीं ये टाइम खत्म हो गया ना टाइम खत्म हो गया ना ये तो उसने एक ही दिया ना सही so one correct answer so 20 marks for Kshitij here so we go to Ravi next so Ravi take your time do properly still you can catch Tabish and Somak just you need more 10 for catching Somak and more 100 to catch Tabish so are you ready?
Yes sir.
Yeah, so 3 2 1 start. So for which following skeletal tumor is radiation routinely done for definitive treatment? Osteo, Ewing's, chondro, pleomorphic sarcoma, Paget's disease. Definitive RT is a treatment option.
Sir, chondrosarcoma.
Chondrosarcoma. C. Okay. Next, all of the following histological features are typical of enchondromas except a typical histological feature of enchondroma: cellularity, lobular architecture, nuclei, occasional binuclear, prominent myxoid change.
D, sir.
D.
Next.
Next. 15 years boy with thigh pain and relieved on night. What is the common investigation for diagnosis? MRI, PET, SPECT, bone scan, ultrasound, CT. 9 years boy, thigh pain.
Bone scan.
Bone scan.
Bone scan. Next.
Which of the following malignancies occur in pre-existing benign bone tumor? Osteo, MFH, FI.
Osteosarcoma.
Osteosarcoma. Last. Which of the following statement is incorrect?
A, sir.
Bit late. कौन सा था आंसर?
A, sir. I said A.
A, लेकिन नहीं टाइम खत्म हो गया था. कोई बात नहीं. How many correct? 2 correct. So 2 correct. 40 marks. Oh, so we think Tavi should be the first person.
Thank you, sir.
Till Aditya can catch Ravi or go beyond so much. So it's interesting. Aditya, do properly.
Sir, there is a humble request. I want to read my own questions.
आप तुम कर सकते हो मुझे कोई प्रॉब्लम नहीं है चलेगा चलो 3 2 1 1
pass. TB and fibula.
Next.
Spontaneous mutation. Sir, options are not changed.
Spontaneous mutations in all patients, autosomal dominant.
The options are osteosarcoma, heterotrophic ossification, synovial sarcoma, or none of the above.
Sir, I will go with what was the B option?
Heterotrophic ossification.
Heterotrophic ossification. Heterotrophic ossification.
Last. Spot diagnosis.
B chondromatic.
Yeah, we can go for first question also if time is remaining.
Sir, can you show the question?
फर्स्ट क्वेश्चन पे जा सकते हैं उसने स्किप किया था हाँ नहीं फर्स्ट का गा दिया पहला स्किप बोला था
ओके
ये स्किप किया था ना तुमने
हाँ सर
हाँ कोई बात नहीं तो इसमें क्या लग रहा है आपको
सर सी इंट्रामस्कुलर लाइफ सॉरी बी वेल डिफरेंशिएटेड लाइपोमा लाइक लाइपोसर्कोमा
ए myxoid liposarcoma.
नहीं गलत था कोई बात नहीं चलो ठीक है नो प्रॉब्लम सो ही हैज गिवन 2 करेक्ट आंसर्स So it's 80 marks. No problem. So last is our final contestant, Abhishek. Yeah, Abhishek. So yeah, so 3, 2, and 1. We can start.
Embryonal B.
Next. Infancy and childhood tumor.
Sir, A. Rhabdomyocytes.
Yeah. Next. Channel sarcoma. Yeah.
Sir, E.
E. Next. Worst prognosis. 3 variables.
Sir, C.
C. Last. Fibrous dysplasia, genetic abnormalities. Fast, fast, fast.
Sir, C.
C. So Abhishek has done here well. 60 marks here, Abhishek. So nice, Abhishek. So our winner is contestant A. Abhishek, congratulations. Yeah, great. So second is Ravi. He has done nice, 140. And Somak is third. So nice, Somak. So first is Tabish, second is Ravi, and third is Somak. Kshitij needs to read a bit more. Aditya and Abhishek were bit tough fighters. So just something. So next time we'll announce this quiz bit earlier so that everyone can register a bit faster. We had few emails that they were unable to join. So they were unable to join because they logged in late. So we had given 10 minutes extra. We started at 6:10. So we will be also more prepared next time. So really great that you stayed till the end and participated very nicely.
Yes,
So
sir.
congratulations.
Sir, I wanted to do this, sir.
Yeah, so any comments from you said that how we can improve it?
Yes, sir.
And we will invite you all for our conference that 24th and 25th.
Basically,
It will
can
be
I,
good event for you.
can I talk, sir?
Yeah, definitely.
Yes, sir. If you kindly remember, I had, sir, also mailed you, sir, 2 years before regarding the this ortho-oncology fellowship there. But I didn't, sir, receive. But I did not, sir, receive. Sir, you told me that we don't have these options currently. So that is why then I went for FND. Basically, I was interested in oncology only. I got a rank 1 at this Tata Memorial Center.
Okay.
But I was dropped in Viva just because I had no experience in the oncology by Dr. Ajay Puri, sir.
Okay.
I was there to learn oncology, but they told me that you don't have any oncology experience. That's why we will not take you.
Okay.
Otherwise, my rank was 1 there also.
Okay.
So I'm also, sir, looking forward
so you
to coming to your institute.
You can come for 1 month first.
Yes.
See the branch how it is. So Nandlal came to us for 1 month. For any fellowship, we said that please visit the center for 1 month.
Yes, sir.
See the branch, it's totally new branch, not routine for orthopedics. So you need to learn what it is, and if you're interested, then you need to proceed further for that branch. So that is best idea. First, come to our center for 1 month, and if you like the things, then it will be good.
Yes, sir, I will definitely come, sir. Because
Definitely, it will be really great. That I had heard Purisa's lecture in 2006. His last slide was that if you are interested in tumors, you can come to Tata Memorial Hospital. So that was a trigger point for me in 2006 that I came to this branch. So there should be some inspiration that you have seen some person, some surgery, something inspirational for this branch, because it's not that glamorous branch as compared to other subspecialties in orthopedics. It's a good branch, and we are looking forward to meet you personally also.
Yes.
So great. So just we will check all the logistics, how this price amount will be transferred to you. So that will be emailed to you, and other things will be done. So that is one just simple formality.
Yes.
So that will be done, and really great that you participated nicely.
Thank you, sir.
Yes, Somak. So what is your plan, Somak? You are in third year or you are past?
No, sir, I'm in third year, sir. After 1 month, I'm having my final exams.
Oh, great, great. Best of luck. Best of luck. You have
Thank
done
you,
nicely. So just I will invite Rajesh Sharma ji, who is the mastermind behind this quiz. So just you can say hi to him, and it is a great
Hello,
effort
sir.
from him also.
Hello, sir.
So he is
Great learning
Rajesh Sharma
experience, sir.
ji, and this is Dr. Nandlal, and other 15 people are working for this quiz. So I clicked this picture just 15 minutes ago, and we will try to upload it also because it's a lots of efforts for any program. So Rajesh ji is doing it regularly, boss. But for us, it was a first time event, and with small technical glitches that some questions were wrongly written. But we will try to improve that also next time. Yeah. Any other comments from any other Abhishek or Ravi?
Sir, they were
Sir, it was a great learning experience for us.
Yeah.
Like I learned a lot. It was a great learning experience, sir,
Yeah.
from you. Like I heard about you, and it was
Yeah.
like
Yeah, Abhishek.
our
Yeah. Anything,
best
Ravi?
experience to learn the oncology from you.
Yeah. Thank you. Thank you. So thanks. So we can finish.
Yeah.
Huh? Yeah. Thank you very much, and congratulations to all our winners and all the viewers who are seeing this quiz on YouTube and other platforms. So we are looking forward to welcome you for our conference. So just send an email from all 6 participants. Just send an email to us, and the other who has not won the prize also, we'll do something for you also. That we can do the complimentary registration and something else for you also. So that can be something
Thank you,
from
sir.
our side we can do. We can help for stay also, that we can do free for you. So that we can do for others who have not won the prize. So
those who
just
have won,
send an email to us,
those,
and we'll do
so
that
those
for
who
you.
have won, they have free registrations or not?
अरे उनका फ्री कर देंगे रे, उनका तो फ्री है ही. तो इनको नहीं, जो
Thank
जीते
you, sir.
उनके लिए भी तो कुछ करना चाहिए ना. So we'll do free
Sir, I will
registration
come
for all
after
of you.
exam and
See,
meet you, sir.
from our side, we can do free registration for all 6 of you, and we'll take care of your stay also. So that also.
Sir, I have actually already registered for the conference.
हाँ, तो we will refund your registration. जिसने नहीं किया है उसका हम free कर देंगे, and we will do free stay for all 6. So that we can do.
Okay, thank you, sir.
Yeah.
Means a lot, sir. Thank you, sir.
Means a lot, sir.
Thank you, sir.
Sir, my university exam is from 20th. So
एक मिनट. So Rajesh ji want to say something. So Rajesh ji.
Yeah. So, guys, congratulations to winner and all those who have done the effort. What we want to appeal, the objective of that this high-tech work happening in oncology, especially in organ preservation and all, should reach all the upcoming orthopedic surgeons and oncologists, so that the benefit can reach to more people. So what we request and expect from you, if you can share about the conference in all your groups in orthopedics and oncology and orthopedic oncology, it will be very helpful. Can you guys promise
okay.
that?
Yes, sir.
Yes,
Sure.
sir. Sure, sir.
Yeah.
It's
Thank you.
already in our consultant group, sir.
Yeah, so it will be really great. So we want maximum participations across the country, and we have good eminent faculties. For 4 international faculties are there. One is from Malaysia, Dr. Vivek Ajit Singh. Dr. Ish Garan is from Philippines. He's head of Philippine orthopedics. And 2 of our good friends are from Nepal. And Pan India, we are all good consultants. So we'll start from basics and we will go to high-end things. And just send an email of all 6 people to us, so that we can do all the formalities for you, for your registration and free stay in Ahmedabad. So
where do we have to
forward
send
to
that?
meet you all. Yeah.
The email
Thank
ID.
you
So
very
where
much.
do we have to send? Where do we have
Just
to
email
send?
on the our portal, the OncoOrthocon email ID.
Okay, sir. Okay, sir.
Yeah.
Okay, sir.
Yes, sir. Sure.
Thank you.
Just log in on our
Thank you,
website. Just get the email and just send an email to us.
Okay,
Yeah.
sir. Thank you.
We'll contact you. Yeah.
Thank
Thank you very much.
Thank
Thanks.
you.
It was
Okay,
really
sir.
great.
Thank you so much, sir.
Sir,
Thank you.
sir.
thank
It was
Yeah.
a great experience.
Bye. Bye.
Thank you, sir.
Bye.